अच्छा वो Hello, doctor. How are you?
Assalamu alaikum.
The one which is basically organizing the national dialogue.
Yes. They are doing a lot of dialogue. Great. It's so nice to see you.
Everybody, please settle down so that we can start the health dialogue for today's session. I would like to start the health dialogue for today with the holy recitation of Holy Quran, and for that.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الرحمن علم القرآن خلق الإنسان علمه البيان. الشمس والقمر بحسبان والنجم والشجر يسجدان. والسماء رفعها ووضع الميزان ألا تطغوا في الميزان وأقيموا الوزن بالقسط ولا تخسروا الميزان. صدق الله العظيم.
Jazakallah. Before starting a formal health dialogue, I would like to ask everybody to please rise for the national anthem of Pakistan. Honorable guests, participants, and all my public health practitioners. I welcome you all. Assalamu alaikum and very good morning to everybody. I'm Dr. Zainab Ali Lakhani from Health Service Academy doing my master's here, and I welcome you all for the Comstech Secretariat. Today on the health dialogue that is improving Pakistan's healthcare system challenges and opportunity seminar. As we all know, the route to better patient care and effectiveness is improving the healthcare system. Healthcare organizations may achieve their goals by offering the improved outcome by focusing the objectives and their targeters, and also by looking forward the information strategies. Pakistan experienced some of the most severe health issues during the start of this decade, and to access the primary and preventative health measures, which are very essential for the women and the children, are not available, for which they are, because of which they are underprivileged and not available for the in the community easily. Working on these challenges, we have gathered here so that we can conduct this health dialogue and establish a purposeful policies for improving the Pakistan's healthcare system. For that, I would like to start the session by calling forward the Honorable Vice Chancellor of Health Services Academy, Dr. Shahzad Ali Khan, to please give a welcome, to cordially invite all the guests and the participants and also present his opening speech.
Assalamu alaikum. Very good morning and thank you very much for being here. I formally welcome the WHO Head of Mission in Pakistan, Dr. Mahipala Palitha, Ambassador Raza Ipri, who is the partner institute in starting this dialogue. And we have honorable guest, Dr. Zafar Mirza, who has been a mentor for public health for quite some time. And he is leading a lot of policy dialogues already in Pakistan. Dr. Arshad, the Chief Executive of Siraj Program, Siraj Saab, Honorable Ambassador of Yemen. He is here and he is also a friend of Health Services Academy and friend of Pakistan. And of course, all the comstech administration who has provided this space. To tell you, honestly, we have a very good relationship with comstech in the form of a lot of OIC countries showing interest in training courses on public health and all other public health related fields. So comstech is organizing and coordinating the linkage of the Islamic countries with Pakistan and of course with Health Services Academy and multiple other universities. Abdul Rashid Saab in ex-DG DRAP, he's also working with the comstech, and we are trying to develop a lot of linkages with Islamic world and Islamic countries. So we recently launched the fellowship programs and Yemen was one of the participants. We also trying to support health trainings in Iran and in Afghanistan and African countries. This is something which this policy dialogue, coming to this very specific policy dialogue, in any country, in order to develop, you need economic development, infrastructure development, and then social development. As you all know, in Pakistan, most of the focus in the past, say, decades had mostly been economic development and then infrastructure development. There was not much done when it comes to social development. So we thought, by we, I mean all the people who are in power corridor, they thought that economic development will be reflected into infrastructure development and that ultimately will develop into social development. That didn't happen. I, as a student of economics, but that's my favorite subject in public health. I studied the trickle-down effect of economics or economic development. That also was not evident in many developing countries, not just in Pakistan. In most countries, the trickle-down effect never came down. The richer get richer, and the poor stayed poor. So, in order to attain the level of development, we always call ourselves for the last 75 years a developing country. Just focusing on infrastructure development like roads and bridges and all other things, and economic development in the form of FDIs and all other industrial and agricultural reforms, you cannot achieve the status of a developed country unless you focus on social development. So for the last few years, there is a lot of talk for social development. And how does social development happens? Two major things, education and health. So the road to social development is through health reform and health betterment, and definitely education. Now, we are lucky at Health Services Academy that we are dealing with both. As in Health Services Academy, we are an education institute. So we are focusing on increasing the education level in various fields of public health. On the other hand, we are dealing with health sector. So most of the trainings, short-term trainings and policy papers, strategies we are involved in, they are dealing with health sector. So we have a dual mandate. Not only that we have a responsibility for education development, but also as a responsibility for contributing into health reform of the country. I think a few weeks ago, myself and Dr. Zafar Mirza, we were already involved in Indus Conclave in Lahore, and there was a very big session on health policy reforms, and it was well taken up. It was like most of the participants, they asked questions, and there were very good interaction on that dialogue. So this happening of health dialogue and this thing where the people are talking about health initiatives, they're talking about health reforms, and people are gathered together. The media is here, the development partners are here, the diplomats are here, and of course my students, Health Services Academy, PhD, and my faculty and my students are here. So this actually gives a very good feeling that we are having a dialogue for improving the health of the nation and how to improve health service delivery, and of course all other elements. Pakistan has, as you already know, a double burden of disease. So on one side, we are the number 4th highest number of tuberculosis cases in the world, highest neonatal mortality, mostly due to sepsis and infections, pneumonia, #1 killer, diarrhea, #1 killer, hepatitis C, you know how much surge of hepatitis C is there. On one hand, we have a very high infectious disease burden. And on the other hand, there is a very fast and rapidly growing epidemic of non-communicable diseases. Yesterday, for 2-3 days, I was in Karachi for World Diabetes Day and a lot of discussion on diabetes. And we came to know that there are 33 million estimated diabetics in Pakistan. So the ambassador of Denmark was sitting there and we talked that it is 33 million is more than the population of Scandinavia maybe, or maybe many countries combined in Europe. So even the country has 33 million diabetics, which is more than the population of many developed countries. This is tip of iceberg. So we need to do something about wellness. We need to do something about prevention, screening, identifying those who are not. And out of these 33 million, 1/4 or 1/3 are not diagnosed. They are in the estimate, but they don't know that they have diabetes. Similarly, we have one of the poorest diabetic control in the world. 6% diabetics having their blood sugar controlled at a level where it should be. On the other side, every hour, 47 deaths happen due to heart attack. This is one of the highest in the world. We have a very high burden of CVD. 47 deaths per hour by heart attack, 1,128 per day, and around 416,000 per year. Majority of these deaths, which have happened due to heart disease, CVD, majority of these deaths, I think 60% are below the age of 60, which is another strange phenomenon. The developed countries, they don't expect such an epidemiology where heart disease is happening at the age of 35 years, 40 years. We call it chronic diabetes above the age of 40. In Pakistan, Diabetic Association of Pakistan has shown a lot of figures where people at the age of 25, 26, 28, 30, 35 are getting diabetics, and they are also getting CV and they are also getting heart attacks. This is a very, very strange phenomenon. So given this high burden of infectious diseases and a very high burden of non-communicable diseases at a very fast pace, we need to think differently, we need to act differently, and that is where the role of such leading public policy experts, health policy expert comes, when we have to sit together and do something about it. Building diabetic clinics, building heart transplant or heart sort of interventional cardiology centers will not help. We have been doing that for the last many years. Every big city now has an institute of cardiology. Every hospital has a diabetic center, but we do not prevent this epidemic. So there has to be a policy dialogue where we need to understand the science of prevention, the science of public health, and of course, the concept of wellness. It is not the disease, it's the sense of physical, mental, and social well-being which makes us healthy. So if we are to be considered as a healthy nation, we should not be putting money only on hospitals and disease centers and disease programs. We should be putting our money to where it should get the maximum prevention. So to me, today's dialogue is very important, such a very high level senior public health policymakers and a very leading professionals and in partnership with us. Hopefully this dialogue will come up with a policy brief or a policy paper and a media brief for all of you to take and disseminate it. And we will be hopefully conducting repeated seminars on a more focused approach. Today is a generic health policy, healthcare delivery system improvement, challenges of healthcare delivery. So we will be talking on a very broader lens. But I think we need to be more specific in next time. So the sequence of these and IPRI, I must appreciate, I've seen since our partnership began, they are very dynamic, very active, and very well connected as well. The Margala dialogue and all these high-level dialogues which they did in the last few days, I was very much impressed, and we are very hopeful that with this kind of policy think tank, with this kind of high-level influential people working with Health Services Academy, along with the media of Pakistan, we will be able to generate a discussion, because public health is all politics, policy is political. How do you make policy? It's political choice. So we need to change the mindset of the decision maker, the policy maker. And for that, we need the intellectuals, the researchers, the public health professionals sitting with a lot of policy makers and of course with the media to generate this discussion. So if we keep on doing such dialogues and trying to identifying some loopholes and trying to suggest some solutions. So our discussion and our dialogues must always be solution oriented. We know the problems. Whenever we go into a dialogue or somewhere, we start talking about the problems only. So to me, the best policy dialogue would be where we provide some recommendations, some solutions. If we don't have, as I always say, if we are not part of the solution, we are part of the problem. It's very simple. So if we should not be part of the problem, we should always be part of the solution. So hopefully all of us sitting here, very good partners of Health Services Academy and comstech and IPRI, we will be trying to develop some solutions, pilot those solutions, and then upscale. The whole science of public health works like this. You just develop a solution which is customized, local, endemic, and then you test it at a small scale, you call it piloting, and then when it works, you upscale it. This is the science of public health. Hopefully, we will be into something like this, not just teaching MS, PH, and PhD and diplomas and everything. Actual policy dialogue, sitting with the people who matter to the most of this policy making, media highlighting the importance of various interventions, and of course, evaluating what we have done. If we don't evaluate, we should not be, feeling good. There is a science which says whatever you have done, you must evaluate and then go for any changes. So I welcome all of you, and hopefully today's dialogue will set a lot of priorities for the future. Health Services Academy would love to continue with a smaller level, like you see mental health, you see nutrition problems, you see social health protection. So we will be having specific focused policy dialogues of very specific things within next, say, 6 months. And then on the basis of that, you can come up with a very overall national policy dialogue. So thank you very much, and welcome again for being here. Thank you.
It was very insightful, and thank you so much, Dr. Shahzad Ali Khan. Now I would like to introduce Ambassador retired Dr. Raza Muhammad Hilal Imtiaz Military, who is currently leading the president of the Islamabad Policy Research Institute, and now working thoroughly on the main challenges and the way out to improve the various frontiers of Pakistan. I would like to give him the mic and ask him to come forward so that he can give us an introduction on the national dialogue to enhance our knowledge accordingly. Thank you.
Assalamu alaikum and good morning, everyone. here and distinguished ladies and gentlemen, especially the youth which sits behind. You are our future, you are our hope, and you are the ones we would like to listen from that what we need to do in various areas. Dr. Shahzad, the comstech, Dr. Faleha, yes, Health Services Academy and comstech also for hosting us here. And the distinguished guests, I have heard that ambassador from Yemen is here. I see the Chinese friends here. Dr. Zafar, I've been seeing him so far, so long. And we are going to have a good lineup of the speakers. And I would like to read their names. Dr. Shahzad Ali, you have already heard, then unfortunately, Minister Kadir Patel will not be here, but he will be represented by Dr. Shazia Sobia Aslam Somaro. We have Dr. Rashid here with us. We have Dr. Palitha Mahipala. Thank you so much, Excellency, for being here with us. And Dr. Rashid is here. We have Dr. Qaid Said coming in. Maybe General Sukhera also comes later on, and Dr. Mubashir from the Health Services Academy. Thank you all once again, and a brief introduction about the Grand National Dialogue. Ladies and gentlemen, it was in the month of May that we started seeing so much of kind of turmoil in our society, some political polarization, some discussions here and there going on, and we started seeing some indicators on the economy and other things which were not very good. Pakistan is a country which is struggling since long with democracy and development. As Dr. Shahzad very rightly said, that we are a developing country, and since 72 years, 73 years, we are still a developing country. I heard a program last evening. Mr. Sehgal was there on that program, and he said that he had addressed 100 CEOs of Pakistan a day or two before. And he said, I asked them to raise your hands, or those to raise hands who have posted loss in their companies. And he said there was none. So when we see that 100 top CEOs sit at a place and they say that they have not posted any loss, then where is the economic crisis? Perhaps the things lies in the management, not in the economy itself. We have great potential. Pakistan has great potential. As I said, we have a youth, and youth is 122 million or more. You are the great asset, and it is up to the elders, up to the government, how to utilize this great asset. We have so much of natural resources lying underneath. You may be astonished to know that by default, Reko Diq is the first gold deposit of the whole world. Second largest deposit of coal we have. We have granite, we have oil, we have such and such things. And the only thing is how to manage things, how to extract these, how to utilize these. See the COVID, Dr. Zafar is sitting here and so many other who are involved in the COVID management. You are one of the world's top countries, rated top most in management of the COVID, despite having so many problems. So हर वक्त हम अपनी बुराइयां ही देखते हैं, अच्छाइयों को देखना चाहिए. But at the same time, we started off with this initiative of Grand National Dialogue. And this national dialogue is not about the traditional security only. It is about the non-traditional security, human security, to be exact to say. So we are going to deal with about 14 topics in this year and in the beginning of the next year, and excluding one topic, which is on the counterterrorism and de-weaponization. Rest 13 topics are on the non-traditional security, and it is very much in line with our national security policy, which was issued in 21, which said empowering the disempowered, or the focus shift from geostrategy to geoeconomy. We are going to deal with various topics like health, water, energy, education, poverty alleviation, and so many other such topics. We are grateful to Health Services Academy for partnering with us in this very, very important topic, which we are going to continue to broach further and come up with some policy recommendations with your inputs for our policymakers. With these few words, I thank once again the Health Sciences Academy and you all for being here. And I'm sure that this is going to be a very, very useful sitting and very, very fruitful discussion. Thank you so much. God bless you all.
It was quite informative. I would like to take a moment to thank Mr. Retired Dr. Raza Muhammad Hilali Imtiaz Military. Now I would like to call forward our chief guest of today's health dialogue, Dr. Mahipala, to the WHO representative to please give us a light on healthcare workforces. Thank you.
Bismillah Rahman Rahim. Assalamu alaikum. The Honorable Vice Chancellor of Health Service Academy, Professor Shashad Ali Khan, Dr. Abdul Rashid, Ambassador Rasa, Excellency, the Ambassador of Yemen, Dr. Safamisa, CEO, Sehat Saulat Program, all the most distinguished, most esteemed experts who are present here today, media friends, ladies and gentlemen. I'm absolutely honored and extraordinarily privileged to stand before you in this wonderful occasion, in this great forum, to have a policy dialogue to set up how we should move forward in health sector improvement. I am very much thankful to Dr. Shashad for inviting me to witness this great event. And I'm delighted to see so many experts among the crowd here, representing many academic institutions as well. And I'm also delighted to see, in particular, the Health Services Academy students are here, who are the future of this country. It's good to have their mindset, how we should go forward and think seriously about what would be the way forward for us to have a better health system in Pakistan. So students who will be the future will, I'm sure in time to come, will play a greater role in policy dialogue with the necessary hierarchy to ensure that Pakistan has a better health system. Dr. Shashad Ali Khan has already elaborated about the disease burden and the challenges we are facing in the health sector. Let me say, in Pakistan, I have seen a lot of positive things. If you travel across the Pakistan, you had a wonderful road network, all motorways. I have not seen in any other country. I may have traveled maybe 45 countries so far, and I have not seen such a wonderful road network. That's in Pakistan. I have been to many universities, the academic institutions, the faculty they have, the PhD scholars they have. It's amazing to see. You know, your academic institutions are so much, and we have so many educated people. And if you look at the number of scientists produced by Pakistan, and by rank, the 7th highest number of scientists produced in the world from Pakistan. They're really great. And as Ambassador Asa said, the COVID response by Pakistan was outstanding, and World Health Organization highlighted and identified 7 countries which have done extremely well, and Pakistan was top in the list. So that shows the potential, that shows the capacity to develop and move forward if you are really committed and identify the right policies in right place. I think Pakistan has the brightest future in the Southeast Asia region. Population is a positive thing. You have so many educated people. You have a young population. You have a young workforce. And if you make them healthier, they do more. They work hard. And I remember sometimes back, the president of World Bank was invited to World Health Assembly. And in his speech, he was throughout talking about the interlink between the economic development and health development. And he was highlighting, if you have a healthier population, they work hard. That leads to economic development. If you have more economic development, you get more resources to develop health. So that's the linkage between these two, which is already highlighted by Dr. Sasad. And we are facing today the high burden of communicable diseases and also very high burden of non-communicable diseases, the double burden of disease, and then mental health as a big issue. And when it comes to communicable diseases, of course, we have strategies, we have plans, we need to implement. And we need to change the mindset of control of diseases to elimination of diseases. I have been heading in our country health services where we were eliminated few diseases. We were able to declare elimination of filariasis. We were able to declare elimination of malaria. We were able to declare elimination of measles and congenital rubella syndrome and HIV, mother to child transmission. And I remember when we discussed about this, many didn't agree. They said, no, we are too early. We have very high burden of malaria, more than 100,000 cases for 20 million population. Many experts said, no, this is not the time. We have to bring it down. But within 4 years, we brought the malaria cases down to less than 1,000 with 0 deaths. That's because we have changed the mindset. If you go on control the same mindset, people feel in last 30 years, we were doing the same thing. There's no change. But the moment you change the mindset, you start to come out with new policies, your focus is different, your commitment is more, your devotion is more, and you go for elimination and success. You become a success. So therefore, I have discussed with the malaria control program, at least we should go for regional elimination, where at the moment, the Punjab, it's a country, 120 million population, number of malaria cases are so low. We can declare very quickly malaria elimination in Punjab. So what I'm trying to say is in communicable diseases, we have solutions, evidence-based solution, time-tested in many other countries. Those things are available, so we need to implement and we can move ahead. And we have seen tremendous progress as well. When it comes to NCDs, those are chronic diseases, lifestyle-related diseases. So your intervention has to go beyond the health. It has to be social interventions. It has to be many other interventions. For example, so one might see if we invest on putting up open gyms across the country, have walking tracks, how it's going to be help to health? It's really going to bring down your heart disease numbers. It's going to bring down your even mental, issues. It's going to bring down your cardiovascular diseases and also diabetes. So it's an intervention or investment by non-health sector, but for health. And actually, ladies and gentlemen, health interventions, if you look at 60% of health interventions are non-health. 40% it comes to health. Look at the unhealthy diet we consume daily. It's beyond health. We need to get the media friends to highlight this. And Pakistan, the consumption of trans fatty acid is the highest in the world. So it's changing risk factors is the way forward for non-communicable diseases. Smoking, unhealthy diet, physical inactivity. And then, of course, you need to think about the air pollution and so on. So if you reduce the risk factors, we call population-wide interventions, you bring it down. Then, of course, we need to look at how we are going to treat. We have already a disease burden, 55 million people with hypertension. And it is said 20 million diabetics. Now, Dr. Shashad said it's 33 million diabetics now. It's like a huge country, the whole country is having diabetics. So we need to bring it down, but the easiest way is through the primary healthcare services. Now, this is the era we talk every day about universal health coverage. And Professor Sapamisa is here. He will talk more on this. He's a authority in the country for primary healthcare and universal health coverage. This is the way forward. Integrated service delivery and treating all these patients at the primary healthcare level. You can have primary prevention, secondary prevention, And then, of course, you need some tertiary prevention and interventions at the secondary and tertiary level. But if you focus only on tertiary care and secondary care, it's like you have a bottomless spot, you are putting water. It's not going to retain. You need to really promote health. You need to prevent diseases and then integrate the service delivery at the primary healthcare level. So for the future dialogue, I would like to highlight, given this context, 2 points. One is countries moving forward very strongly on primary health care for universal health coverage. At the moment, USC index is 50%, but aim to reach 65% by 2030. And I think one of the best document how to move forward on strengthening primary care in the world, if somebody wants to study, it's in Pakistan. The Universal Health Coverage Benefit Package, which has been developed using DCP3 tool, was the best document, Professor Sapamisa, I have so far gone through. I'm studying now because I was asked to do an oration, so I was trying to go through all the steps taken. It's a 3 years job done, job well done. You have the wonderful document in place. So now we need to implement it. So on pilot basis, I think it's going to be implemented. And then, of course, you will have a network of healthcare institutions which deliver integrated care for malaria, TB, hepatitis, all together. You are testing all that available in the primary healthcare center, which is very close to the people. And then the NCD interventions and RMNCH intervention, mental health services, all that is integrated in the closest institution to the people. So access to healthcare will be very much improved. So this is one of the intervention I think decided by the government is having the top priority now. So we are suggesting different ways of getting finances for that. But this is one of the things we need to really move forward. WHO has tested this with a model of care. Again, Dr. Sapamisa was so much supported us in this and tested on pilot basis how we are going to scale it up. 88 interventions are being selected for this. I think if you implement this, your future is very bright. Number 2, the Share Saulat program. Now, everywhere we talk about universal health coverage. What does it mean? Universal health coverage is nothing but delivering of promotive, preventive, curative, rehabilitative, and palliative healthcare services close to the people without financial hardships. Now, out-of-pocket expenditure at the moment is 50% or above 50%. Share Saulat program initially focused on marginalized group, poor people. When they get a heart attack, need a bypass operation, there's no way. Now there's a health insurance system which really focus on that. So I don't want to go much detail because we have the authority here. But the 2 point again and again and again, I would like to highlight, we need to really focus on primary healthcare strengthening and move ahead with the implementation of essential health service benefit package as one of the top priority for the country. And secondly, to ensure that financial protection is there and targeted intervention through the Share Saulat program. And we have to have a balance, otherwise secondary and tertiary care will be mushroom and primary care will be compromised. And your available budget, much will be into Share Saulat program rather than coming to primary healthcare. So we need to really have a balance in this and move forward with this balance. I am sure in 10 years down the road, Pakistan will have the best healthcare system in all Southeast Asia. I'll stop here. Thank you so much.
Thank you so much, sir. As we all know that WHO is working a lot in improving the healthcare system of Pakistan. Now moving forward with our another well-reputed speaker, Dr. Zafar Mirza, Professor of Health System and Population Health, School of Universal Health Coverage, Global Institute of Health Development, Shifa Tamir Millet University, Islamabad, to shed light on the universal health coverage based on disease control priorities. 3, which is a crucial component for making the health guidelines and health policies.
Thank you very much. Thank you for your kind words. Bismillah ar-Rahman ar-Rahim.
इसके जो आपके सामने
Worthy hosts and collaborating organizations and their representatives,
ये है सर,
distinguished guests.
yes.
First of all, let me appreciate the fact, like Dr. Shahzad was saying, that this event has been organized
Mic,
on healthcare and improving healthcare, looking at the challenges and the opportunities. I think COVID-19 has brought a new focus on health and healthcare. And I think this is the, if you ask me, in global health today, this is the biggest opportunity for health, because the world political leaders have realized that one global pandemic can actually cost trillions of dollars and drag down the national economies, which they will take decades, if not years, to recover. So I think the greatest opportunity currently from a political context is to seize this by upscaling, uplifting the healthcare systems, and more so in low and middle income countries. My understanding of today's event is that it is a dialogue, it is a discourse on different aspects of improving healthcare in the country. And as a student of public health, as a student of health systems, I have this long-held view and belief that the simple idea, without being simplistic, is the human right to health. And since I've been asked to talk about universal health coverage, to me, universal health coverage is operationalizing the right to health. If somebody asks you that how you can implement the right to health, the answer is 3 words: universal health coverage. Because the universality of it and the coverage aspect of it ensures that everybody, without any discrimination, without any regard to who they are, what sex they belong to, what socioeconomic status they belong to, whether they are urban dwellers or whether they live in remote villages, whether they are Muslims or Christians, whether they are black and white, black or white, everybody, every human being has a right to health, and it is the state's responsibility to ensure that right by establishing universal health coverage in their national jurisdictions. So that's what it is. That's the long and short of it. In terms of understanding the importance of universal health coverage, I have promised with Dr. Shahzad that I'll come to Health Services Academy and speak with your faculty and your students on this topic, and I will do so, where we will go into the greater depths and greater details of universal health coverage as a science. It is a science. It is not just a policy, it is not just a strategy, and it is not just a dream. But today I will just give you a very brief overview of universal health coverage, some of the achievements which have already been made in Pakistan, and some of those challenges which are still there. And any dialogue, any policy focus on improving healthcare in Pakistan, or for that matter, many other low and middle income countries, must take into account those factors that I'm going to highlight. But the question is also that these discourses and these dialogues and these seminars must also be channelized into policies. There must be a process, well thought out process, that this discourse and this time and effort, which is put in all these discussions, must also be translated into policies, and policies must be implemented. So first and foremost, can you see all? The light is okay, you can read. So you ask different people about universal health coverage, even people who are working in the health sector, and you will get different understandings and different definitions and different conceptualizations of universal health coverage. I have seen at very high level, high policy level, even in the federal cabinet, people continue to confuse universal health coverage with Sehat Sahulat program, for example. The universal financial protection or universal health insurance is one important, one essential, very significant component of universal health coverage, but universal health coverage is much bigger and much larger than financial protection or social health insurance. But I have seen discussions at a very high level, the highest possible level in Pakistan, where people continue to mingle these two concepts and continue to give their long speeches based upon wrong conceptualizations of these two concepts. So universal health coverage means that all people, as I said, without any discrimination of any kind, and communities can use the 5 kinds of health services. That is preventive, promotive, curative, rehabilitative, and palliative, that they need of sufficient quality to be effective, while also ensuring that the use of these services does not expose the user to financial hardship. And that's where the financial health insurance comes in the larger concept of universal health coverage. You all know about SDGs and SDGs agenda and the 7 goals and the interlinkages and the interdependence of all these goals. None of these goals, I think the most important thing which needs to be understood about SDGs is that none of these goals can be accomplished without the help of other goals. There need to be a parallel progress and parallel advance in each one of these goals, complementing each other, and then only the sustainable development agenda can be advanced. And health has a very special importance in it. Actually, I used to say that none of the other goals can be advanced if there is no progress on sustainable development goal number 3. That is good health and well-being. Because human health is a precondition for human beings to work on human development. It is as simple as that. If you are not healthy enough, you cannot work and you cannot invest, your economies go down, your national securities go down. And I'm so glad that General Saab mentioned about national health, national security policy of Pakistan, which for the first time in this country has actually included the humanitarian aspects of national security. One thing that people have realized is, after global pandemic of COVID-19, is that conceptualizing national security without human development is such a big folly. It is such a big mistake. And that's why when my friend Moeed was working on developing national security policy, we had long discussions. And I'm so glad that not only that Pakistan also distinct itself by having a explicit, publicly available first national security policy among developing countries and even in high-income countries. And this policy is such a comprehensive document that it includes not just the traditional conceptualization of security, but also human dimension of security, without which the national security in every sense of the word also get compromised. The global target for universal health coverage is very clear. The target 3.8 of universal health coverage reads, achieve universal health coverage, including financial risk protection, access to quality essential healthcare services, and access to safe, effective, quality, affordable essential medicines and vaccines for all. And this is all to be achieved by 2030. As you know, that the timeline of the Sustainable Development Agenda is 2030. Now, Pakistan is good at localizing, incorporating the international commitments in its domestic policy frameworks. Actually, we have been always very good at it. That's another story, that what do we do with those frameworks? And what do we do with those policies? So Pakistan was one of the first countries, not the first country, one of the first countries which actually very explicitly incorporated SDGs agenda in its national development policy, which influenced all other sectoral policies in the country, including health policy. So advancing universal health coverage is part of national vision framework, and all top-level policy documents on human development, national development, you will see references, and very explicit references, to SDGs and universal health coverage. So there is no dearth, and there is no gap, and there is no need for asking better policies, actually, in this area. Our 12th five-year plan, in which we are right now, this is the framework of that. And as I said, UHC is very much part of it. Our Pakistan National Health Vision 2016 and 2025 very explicitly also talks about universal health coverage and availability of essential health care for all Pakistanis. Now, I want to invite your attention about the conceptualization of the healthcare system in a country. How healthcare systems are organized to deliver what, to achieve what. Health system and health services is a size. It is no more imagination of a lone policymaker sitting somewhere thinking about the betterment of health system in the country. It is a very well-established science now. And World Health Organization has been promoting health system and its development and all what goes into it in a very systematic way. So on this slide, what you see is that there are some building blocks, well-established building blocks of a healthcare system. You need health financing, you need health workforce, you need health technologies, health information, health infrastructure. In order to provide coverage and healthcare to all the people, in order to have improved health of the people. This is the theory of change, if you like, of improving healthcare in the country, in any country. But if you think more about it, you realize also that all what is organized in the name of healthcare system in a country ultimately has to be translated into health services, because that's what people get. All financing, all health workforce, all technology, all innovation, all health information are tools to develop a package of health services which can be delivered to the people, and people can have access to them in order to benefit from them, in order to take care of their health and their loved ones' health. So this is why health services is the centerpiece of any healthcare system. If health services are the centerpiece of the healthcare system, then we have to think and dwell more that what health services are made up of, what kind of health services are needed, at what level of healthcare they must be delivered, and who should deliver them. So at global level, this has been a debate and discussion and research effort spanned over more than 25 years, that especially in those countries which are resource scant, which are low and middle income countries, with less resources to be spent on healthcare of the people, how we should prioritize that which health services should be provided to people at what level of healthcare. And these 9 volumes that I'm showing you is a result of this 25 years of human endeavor in health services research, looking at each one of the health service, looking at the feasibility of its delivery, looking at its cost, looking at its cost effectiveness, and then coming up with a global generic package of health services which must be delivered at the low and middle income countries. Disease control priorities, the work that I just was talking about, which is funded by World Bank, WHO, Bill and Melinda Gates Foundation, and many other organizations over the years. Ultimately, the synthesis of this quarter of a century work is 218 essential health services, which must be delivered, and if could be delivered to the people, more than 90% of the healthcare problems can be taken care of in low and middle income countries. And as Dr. Palitha was saying, that it is not just, can I have some water, please? A bottle of water. As Dr. Palitha was saying, that 60% of the health services or healthcare is dependent on factors which are not directly in the control of traditional ministries of health. 60%. water and sanitation, environment, food, transportation, housing, and you name it. There are so many other relevant ministries. And this is why in WHO, we have developed this terminology of whole of government approach to health. Whole of government approach to health. Ministry of Health is a conduit to deliver directly a limited number of health services to the people, but there is a huge plethora of services around those health services for which ministries of health cannot be relied upon because it is not in their mandates. And they have to collaborate with other ministries. And this is why the term intersectoral collaboration has been born. And this is why intersectoral collaboration is so much emphasized in our systems. And this work of DCP3 has not neglected this very important dimension. They have also shortlisted 71 intersectoral services, which, if a functional collaboration exists, can be delivered to the people and a holistic healthcare can be provided to the population. UHC talked about 5 kinds of services, and there are platforms of deliveries for these services, which are also 5. I call it 5 by 5. 5 kinds of services which must be delivered at 5 levels of the healthcare. And what are those 5 levels of healthcare? At community level, meaning at the household level, through, in our case, for example, through lady health workers. Primary healthcare, first level primary healthcare facilities. In our case, our BHUs and RHCs and general practitioners in the private sector. First level hospital. In our case, the C-level hospitals and district level hospitals. Tertiary level hospitals, where medical education also takes place and advanced healthcare is delivered. And at population level. People often confuse community level and population level. Let me clarify this. The health services which must be delivered at population level includes those services which can be delivered en masse. A health education campaign on television curbing the use of tobacco is a service which must be delivered at the population level. Mass screening programs are population level services, so on and so forth. But what is most important, and if you can remember one point which you can remember this event about, is that there is also a health service research which informs us that 70% of all these 218 health services can be delivered at the primary healthcare level, depending upon how you define primary healthcare. Community level and primary healthcare facility level, if you just combine these two, and in some cases for inpatient facilities, first level hospitals, these 3 levels constitute primary healthcare. And 70% of healthcare can be provided at the primary healthcare level. So obviously, all what I'm saying has a very serious implication on health policies of the countries. How we allocate our sources, how we organize and strengthen our primary healthcare and other levels of the healthcare, and how we train our health workforce to deliver these services at appropriate levels of the healthcare. In Pakistan, as Dr. Palitha was referring to, we spent about 3 years to develop a first national essential health service package based upon and guided by this DCP3 9 volumes. And we even shortlisted from 218 to 117 services. If delivered properly in Pakistan, with emphasis on primary health care, with properly trained health workforce, more than 90% of the healthcare problems in Pakistan can be taken care of. And Pakistan has made a lot of progress. Rightly so, we can actually take credit for developing a very rigorously a national essential health service package, taking lead from federal government. Provincial governments have also developed their provincial packages, and financial protection has been taken care by the Sehat Sahulat program for inpatient problems. Of course, it is not enough, but indeed it is monumental in the context of a country like Pakistan, which spends so little on health, which is one of the major problems. Pakistan, by the way, is one of the lowest spenders on healthcare of the people. It is bracketed with the lowest income countries in sub-Saharan Africa, lowest spender in whole of South Asia. So when there is such a scarcity of resources, you have to prioritize. There is absolutely no other option. And this is the way to go about it. And this is not to say that we should not spend more. We need to actually phenomenally increase our health financing. But the question is that if these are the most important considerations for improving healthcare in the country, are we preparing our future health workforce in our medical colleges and in our public health institutions, which are properly trained, informed, and educated about these considerations? I have this contention that an average medical graduate in the country today has no idea that even this country has a national health policy and where to find that national health policy. I have my contention that an average medical graduate in this country has no idea that how the health system is organized in this country, and 90% or more of medical graduates have never visited even a basic health unit. This is where our problem lies. So we have to fundamentally shift our medical and public health education in the country if we are serious and sincere about improving our healthcare. The second very important question is, you must have heard this, that more than 60% healthcare is actually located and delivered in the private health sector in the country. Our all dialogues, discourses, seminars on national health policies are actually limited to public sector. We have no idea as policymakers, as public health practitioners, as people who are interested to improve things in their sincerity, have no idea that what is going on in private health sector and how to engage with the private health sector in order to establish a meaningful national health service in the country. My last slide. I have worked out these 8 fundamental shifts which needs to be taken if we want to improve our healthcare system in the country. Actually, there are 2 more, and I will talk about them in a minute. First of all, we need to shift from policies to implementation. We have marvelous policies. We are an over-legislated country. We fail in enforcement. enforcement of policies and enforcement of laws. We need to shift also. When I say shift, this does not mean that you don't do one thing and only do the other. A shift meaning that you add on another dimension, which I'm urging you to think, to shift to. So healthcare to health security. In Pakistan, not only every year, every few years, but actually every few months, we are struck with a healthcare emergency. Whether it is a natural catastrophe or it is a man-made crisis. So our healthcare system cannot afford just to think and plan about peacetime healthcare. Peacetime, I'm using as a euphemism for normal circumstances. We are constantly struck by emergencies, floods, earthquakes, and so many other kinds of emergencies. So we need to think in terms of health security more than healthcare. We have to also move from health sector to multi-sectoral, and I will not elaborate. I have just explained this to you. We have also to move from curative only to preventive. Again, I don't think so I need to explain that. A liver transplantation, which requires 5 million rupees at least in Pakistan, could be prevented if few preventive actions could have been taken at the right time by the right people. From tertiary, we have to shift to primary. From acute, we have to shift to chronic care. As Dr. Balita was saying, I think Dr. Shahzad was also alluding to it, that our non-communicable diseases and the burden due to them is phenomenal. And unless we organize our healthcare system, which can take care of the people's healthcare problems, which are non-communicable, and hence by definition, they are chronic and require a lifelong treatment or care. Our healthcare system currently is not organized to take care of people for lifelong care. And we also have to move from vertical to integrated approach. We have to stop thinking about this is AIDS program and this is diarrheal program and this is immunization program. They all need to be woven into an integrated package of health services, which must be delivered at the appropriate level of healthcare, as I just mentioned. And also from age-specific care to a life course approach. I hope I have provoked some thinking. Thank you very much.
Thank you so much, Dr. Zafar Mirza. Now I would like to request Dr. Abdul Rashid, who is the main lead from the DRAP, the Drug Authority and Regulation in Pakistan, to come up and elaborate the knowledge about the how to collaborate with OIC countries regarding the comstech and this improving healthcare system of Pakistan. Thank you.
This is. I will talk on behalf of Professor Dr. Muhammad Iqbal Chaudhry, Coordinator General Comstech. It is a great honor and immense pleasure for me to be here in this august house. I'm highly honored and privileged to have been given the opportunity to address on this occasion of health policy dialogue. I'm thankful to Professor Dr. Shahzad Ali Khan, who is my teacher and also the mentor, Vice Chancellor, and I must say, as President of Pakistan said, the outstanding Vice Chancellor, University of Health Service Academy. My ex-boss, Dr. Zafar Mirza, Dr. Muhammad Arshad, Dr. Qaid Saeed, Chief Executive Officer, Islamabad Health Regulatory Authority of Pakistan, Major General Asif Mumtaz Sukhera Saab, ex-Surgeon General Army of Pakistan, Dr. Raza Muhammad, the Ambassador of Yemen Embassy. I think he has gone. Also the diplomats from different embassies, from UAE, public health specialists, and other respected guests. Assalamu alaikum. I will talk a little bit different because I have 38-year professional experience in Pakistan, being a regulator of Drug Regulatory Authority Pakistan. It was the dream of Dr. Zafar Mirza in 1988 that there should be separate regulatory authority in Pakistan who should regulate the medicines, vaccines, biologicals, and other therapeutic goods. And Alhamdulillah, as a technical person, on 13th November 2012, we, as a technical person, we have promoted DRAP Act 2012. So this was the dream of Dr. Zafar Mirza, and we notified the DRAP Act 2012 in a relative form. This is just with the reference of Dr. Mirza. According to World Health Organization, a health system consists of all organizations, people, and interventions whose primary intent is to promote, restore, or maintain health and well-being. The fundamental purpose of healthcare is to optimize, very, very important, that is quality of life by enhancing health. Commercial business focus on creating financial profit to support their valuation and remain viable in the market. Healthcare must focus on creating social profit to fulfill the quality care in the society, providing social healthcare protection and equal access to the quality healthcare has significant positive effects on individuals' public health, economic growth, and development. Quality health services must be safe, must be effective, patient-centered, timely services should be given timely, equitable, integrated, and efficient, as mentioned by different speakers before this. Numerous flaws exist in Pakistan health systems. Dr. Shahzad Saab ne kaha, mere khayal mein foreigner bahut kam hai. I think Thaman Pukwan, Meo Ventima, if I speak in Urdu. Mujhe Chinese aati hai, to isliye zyadatar basically Dr. Shahzad Saab ne kaha hai ki yahan problems ki baat na kare, yahan solutions ki baat kare. मैं उनका स्टूडेंट हूं, तो मैं मेरा जो 38 साल का एक्सपीरियंस है, जो मैंने जो एक देहात की गली से लेकर इस्लामाबाद कैपिटल में पहुंचा, मैं 84 से मैं इस्लामाबाद में हूं, और जो मैंने एज ए टीचर और एज ए रेगुलेटर जो हेल्थ के प्रॉब्लम्स देखे हैं, वो जरूर मैं यहाँ मेंशन करना चाहूंगा, ताकि वो प्रॉब्लम सामने आएंगे तो फिर उसका सोल्यूशन भी होगा. The one of the problem is poor governance in Pakistan, restricted access to resources. And if the resources are there, there is unequal distribution of resources, a poor health information system, particularly at primary healthcare level, corruption in health industry. I am a regulator of health industry. And a dearth of skilled workers. There is a shortage of skilled health workforce in the country. Cataclysmic floods have already damaged over 1,460 health facilities in sensitive areas, compounding logistic challenges and throwing up new barriers to healthcare access. With vast areas of Pakistan still underwater, life-saving supplies, risk delays, and future displacement complicates outreach. Standing floodwaters can also spread infection diseases, contain chemical hazards, cause injuries, a shortage of foods and shelters, and many more. Each year, flood causes more deaths than any other hazards related to thunderstorm. Around, as mentioned by Professor Dr. Shahzad Ali Khan, around 33 million people in Pakistan, or 1 in 7 people in the country, have been impacted by devastating floods. For context, that is the equivalent of almost half the population of the UK and more the population of Norway. Families have lost their homes, livelihoods, and in some cases, loved ones. The immediate health impacts of floods include malaria, gastrointestinal diseases, diarrhea, respiratory infection, drowning, injuries, hypothermia, and snake bites. Health risks also are associated with the evacuation of patients, loss of health workers, and loss of health infrastructure, including essential drugs and supplies. Other key measures can be taken to improve healthcare sector of Pakistan. Number 1 is control population growth, increase literacy rate, increase health budget up to 8% or 10% of GDP, control corruption in public health projects, provincial coordination and corporation of health services. This is very important that federal government should have a very close liaison, coordination and cooperation on health sector. And otherwise, there will be not one policy, there should be separated policies. Proper check on quackery, exchange of human resources, and rational use of life-saving drugs. Some of the strategies for this national policy dialogue, number 1 is the political will. जैसे पालिका ने कहा कि मैं 45 मुल्कों में गया हूं, जो पाकिस्तान के सड़कों का नेटवर्क है वो मैं उन्होंने 45 मुल्कों में नहीं देखा. दिस इज अ पॉलिटिकल विल. तो मेरी ये रिक्वेस्ट होगी कि जो जिस तरह सड़कें बनाने के एक पॉलिटिकल विल है, वो इंफ्रास्ट्रक्चर को डेवलप करना चाहते हैं, मेरी गवर्नमेंट से, फेडरल गवर्नमेंट से, प्रोविंशियल गवर्नमेंट से रिक्वेस्ट होगी कि हेल्थ केयर सर्विसेज को भी और पॉलिटिकल विल के तौर पर लें और इनकी ये जो फैसिलिटीज हैं उनको बेहतर किया जाए. द सेकंड वन इज लॉन्ग टर्म इकोनॉमिक ग्रोथ, बायोमेडिकल इंटरवेंशंस, इंप्रूविंग water sources and sanitation. This is very, very important. Public health, better diets, balanced diet is a choice. Improving women rights and maternal health. If you go to the periphery, I belong to a village where the main problem is maternal and child health and newborn health services. On job training of healthcare professionals, as mentioned by different speakers. Provision of safe, effective, quality medicine with rational use of drugs at affordable prices with the services of clinical pharmacists in Pakistan. मैं डॉक्टर जफर मिर्जा से he is expert in public health कि पाकिस्तान में जब तक फार्मासिस्ट की सर्विसेज को इस्तेमाल नहीं किया जाएगा उस वक्त तक पाकिस्तान में हेल्थ सिस्टम बेहतर कभी नहीं हो सकता. ये मेरे अल्फाज आपको याद रहेंगे. The last one is digital health transformations. हम दुनिया का 5वां बड़ा मुल्क हैं. हमारी पॉपुलेशन जो है 220 मिलियन से ज्यादा है. हम कई मुल्कों के बराबर जो है हमारी पॉपुलेशन है. जब तक हम डिजिटल फैसिलिटीज पाकिस्तान में नहीं लाएंगे, ये जो मैनुअल सिस्टम है, इसे कभी भी हम हेल्थ सिस्टम में बेहतरी नहीं ला सकते. So this is essential there must be digital health transformations. Biotechnology is widely used in the development of several innovative techniques for diagnosing and treating and preventing disease. It helps in providing effective treatments and prevention measures at different diseases through its interventions of novel drugs and recombinant vaccines. Moreover, biotechnology improves human lives in plenty of ways. It keeps people healthy in their daily lives through the advanced biotech products. In human healthcare, biotechnology products include quicker and more accurate diagnostic tests, especially just like corona, therapies and fewer side effects, and new and safer vaccines. We can now detect many diseases and medical conditions more quickly and with greater accuracy because of new biotechnology-based diagnostic tools. Moreover, biotechnology has the potential to create novel diagnostics, vaccines, drugs, and other fundamental countermeasures needed to detect, prevention, and treatment of the diseases. Now, I will briefly discuss the role of comstech in 57 Muslim countries. OIC, Organization of Islamic Cooperation, consists of 57 member countries, and they are spread in 4 continents with a population of 1.9 billion, with a growth rate of annually 2.15. So this 57 countries of the Muslim Ummah, this comstech, this institution is working for their science and technology. Comstechs project countries' soft image as scientifically leading nation. About Pakistan, the second is strengthen science-based technology, assessment of human and material resources of 57 member states, identification of scientific and technological needs and requirements of the Muslim Ummah, enhancement of cooperation and coordination in science and technology fields with a view to achieving collective competence for solution of the problems, creating of an effective institutional structure for planning, research, development, and monitoring of science and technology initiatives at different levels. Capacity building of stakeholders through exchanges and fellowships. Large-scale training program and support to science events. And moreover, comstech have prepared a 5-year action plan on health for African Muslim countries. In the last, I'm thankful to media from electronic and print media. More than 10 TV channels, they came to for the coverage of this national policy dialogue. We appreciate their role for creating the awareness, advocacy on the services of the health system. And we are also thankful to the very, very important institution, EPRI. They are playing very good role on research of health systems in Pakistan. So again, once again, I appreciate the media from all, especially the DAN, because they are also giving large coverage for health system. Thank you very much.
Thank you so much, sir, for advancing our knowledge regarding the challenges and the solutions.
ये स्टूडेंट्स बैक सीट्स पे थोड़े रेस्टलेस हो रहे हैं, प्लीज पेशेंस और नोट्स लें. एंड में यू गाइस हैव टू कंट्रीब्यूट टू द पैनल डिस्कशन. आप लोगों ने कंट्रीब्यूट करना है सारे पिलर्स में, जो पॉलिसी से निकलेगी. वी नीड योर इनपुट. तो प्लीज डोंट बी रेस्टलेस एंड ट्राई टू टेक नोट्स सो दैट यू कैन एक्टिवली पार्टिसिपेट टुवर्ड्स द एंड. थैंक यू.
Our next speaker of today's dialogue is Dr. Muhammad Arshad, the Chief Executive Officer of Sehat Sahulat program. He has been doing a remarkable work in the mainstream of the healthcare system. And I would like to invite him to give his brief introduction on the global and regional burden by shedding the light on the global health financing and social health protection.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم. Ambassador Raza, my mentor, Dr. Zafar Mirza, and all the other distinguished guests, and my future. On the lighter side, when Ambassador Raza was referring youth, he was saying कि वो जो नौजवान पीछे बैठे हैं, नौजवान पीछे नहीं बैठे हैं, नौजवान आगे बैठे हैं, और नौजवान हमें ऊपर से देख रहे हैं what we are doing with their Pakistan and what condition we are going to hand over this Pakistan to them. I'll be bilingual with respect if there's any foreigner here. किसी ने एक बाबा जी से पूछा कि अगर रब, आपका मेरा रब, एक चीज मांगने की इजाजत दे और कबूलियत का वादा करे तो आप भला अपने रब से क्या मांगेंगे? तो बाबा जी मुस्कुरा के जवाब दिया, पुत्र है भी कोई पूछने दी गल, हमने सेहत ही मांगनी है कि सेहत के बिना जिंदगी की सारी रौनकें बेकार होती, जिंदगी सेहत के सिवा कुछ भी नहीं। जिंदगी मेरी हो, आपकी हो, देवता की हो, बादशाह की हो, प्रोफेशनल की हो, लीडर की हो, एक आम मजदूर की हो, उसमें से सेहत माइनस कर दीजिए, पीछे क्या बचता है? कुछ नहीं बचता। तो सेहत इसलिए इंपॉर्टेंट है। 75 साल होने को आए पाकिस्तान को, पीछे मुड़ के देखूं एक पाकिस्तानी की हैसियत से, आप सब में मिलके मुड़ के पीछे देखें तो हमने किया क्या है 75 वर्षों में? क्या दिखाएं हम खुद को और इस दुनिया को कि these are our wonderful achievements on which we and our future generation can be proud of. बहुत समेटूं अगर बात को तो शायद 2 चीजें दिफाई मैदान में और 2 चीजें सेहत के मैदान में कुल जमा पूंजी हैं, कुल असासा हैं इस पाकिस्तानी कौम का। एक वो जिसे आप सब जानते हैं, आपका न्यूक्लियर आर्सेनल, न्यूक्लियर सिस्टम और उसका डिलीवरी सिस्टम, जो एक्यू खान और उनकी टीम ने बनाया था। दूसरा मैं कहूँगा दिफा के मैदान में तो एक और काबिल फख्र चीज है जिसको हम तमगे के तौर पे यहाँ अपने सीने पे सजा सकते हैं, और वो है दहशतगर्दी के खिलाफ एक कामयाब जंग जीतना। वो भी आसान नहीं था, बहुत मुश्किल था। जो इस वारफेयर को जानते हैं वही समझेंगे मेरी बात को ज्यादा आसानी से। और अगर हेल्थ की बात करूं तो अगेन देयर आर 2 अचीवमेंट्स। One is fighting and winning the war against COVID-19. Luckily, I was part of NCOC. Thanks to Zafar Mirza. वो जो कहते हैं पाकिस्तान में कि हम हमेशा पोलराइज्ड ही रहते हैं, उंगलियां एक दूसरे की तरफ ही उठाते रहते हैं, तो मैं गवाह हूं उन लम्हात का जब एक 8 बाय 20 की फिट की एक मेज हुआ करती थी, बाएं हाथ पर 8, 10, 12 हाजिर ड्यूटी जर्नल, सीधे हाथ पे 10, 12 कैबिनेट मिनिस्टर्स, पीछे हम गवर्नमेंट ऑफिसर्स, लेफ्ट साइड पर हमारे हेल्थ केयर एपिडेमियोलॉजिस्ट और एक्सपर्ट्स, और पीछे 4 एजेंसियों के नुमाइंदे, और स्क्रीन पे हर सुबह 10 बजे बिला नागा 4 सूबों के चीफ मिनिस्टर्स या हेल्थ मिनिस्टर्स इकट्ठे हुआ करते थे खानदान की तरह, और इस जंग को उन्होंने लड़ा था। और यकीन मानिए बाहर जाके वो जो मर्जी पॉलिटिकल पोस्चरिंग करते रहे हों, लेकिन अंदर मैं गवाह हूं इस बात का, जफर मिर्जा साहब भी और जो बाकी एनसीओसी के मेंबरान थे वो सब गवाह हैं। एक खानदान की तरह जुड़ के, चाहे वो उधर से सिंध के चीफ मिनिस्टर हों, एजेके के चीफ मिनिस्टर हों, पंजाब के चीफ मिनिस्टर हों, एक कौम, एक फैमिली की तरह जुड़ के इस खौफनाक जंग को जीता था। कोविड वाज टोटली ए न्यू फिनोमेना, ए न्यू एनिमल इन अवर वर्ल्ड। डायनासोर से भी बड़ा था, साइज पर न जाइए, बड़ा खौफनाक इम्पैक्ट था उसका। और आखिरी अचीवमेंट अगर कहूं, कोविड-19 वाज एपिसोडिकल अरेंजमेंट, लेकिन अगर लॉन्ग टर्म में मैं गुजारिश करूं तो आपकी यूनिवर्सल हेल्थ इंश्योरेंस UHI, जिसे थैंक्स टू फॉर्मर प्राइम मिनिस्टर, जिसको बहुत उन्होंने उसको प्रमोट किया, सेहत कार्ड के नाम से आप जानते हैं, इसका ब्रांड नेम सेहत कार्ड है, कौमी सेहत कार्ड। ठीक कहा डॉक्टर जफर मिर्जा ने, यूनिवर्सल हेल्थ कवरेज इज अ गोल, यूनिवर्सल हेल्थ कवरेज is a goal, while the universal health insurance is a medium to achieve it, and one of the key components. सेहत की 3, without going academic definition, सेहत की 3 तरीकाकार होते हैं इलाज के लिए, जो मुझे या आपको जिनसे वास्ता पड़ता है। एक OPD, जहां नजला, जुकाम, खांसी होता है और आप महल्ले के क्लिनिक को डॉक्टर के पास जाके इलाज करवाते हैं, उसमें थोड़े से पैसे चाहिए होते हैं। हर आदमी अपनी बिसात के हिसाब से शिफा इंटरनेशनल या गली के कंपाउंडर से इलाज करवा देता है। न उस खानदान को, न उस शख्स को, न जिस्मानी खतरा होता है और न कोई माली तबाही का अंदेशा होता है। दूसरा, क्रोनिक मेडिकेशन, डायबिटीज, ब्लड प्रेशर, जहां लंबे अरसे के लिए दवा खानी होती है, लेकिन फिर भी हर महीने का खर्चा थोड़ा होता है, 2000, 4000, 5000, उससे भी गुजारा किया जा सकता है। उसमें भी खानदान की न माली न जिस्मानी तबाही का अंदेशा होता है। लेकिन जब हम बात करते हैं हॉस्पिटलाइजेशन की, जब हम बात करते हैं कैटेस्ट्रोफिक हेल्थ केयर एक्सपेंडिचर की, तो यकीन मानिए, खानदान चाहे कितना ही बड़ा क्यों ना हो, इनकम कर्व की चाहे किसी भी पीक पर क्यों ना बैठा हो, उसकी खानदान के जिस्मानी और माली तबाही यकीनी होती है। आज से कोई 1.5-2 बरस पहले की बात है, मैं कराची में स्टेट बैंक की लीडरशिप के साथ एक मीटिंग करने गया हुआ था। ऑन द साइड नोट, जब हम कॉफी पी रहे थे, तो डिप्टी गवर्नर साहब पूछने लगे कि अर्शद साहब, डू यू हैव एनी आइडिया कि पाकिस्तान में यार इनकम इनइक्वालिटीज कितनी हैं? तो मैंने मुस्कुरा के जवाब दिया कि हाँ, जब मैं बिजनेस स्कूल में था, IBA में पढ़ा करता था, या फिर आज हम पॉलिसी लेवल पे जो प्रेजेंटेशंस या मीडिया स्कैन करते हैं, तो थोड़ा सा अंदाजा है। बट आई सेड आई वुड लाइक टू हेयर फ्रॉम हॉर्सेस माउथ। मुझे आप बताइए, इकोनॉमी मैनेजर तो मेरे आप हैं, स्टेट बैंक चलाता है पाकिस्तान की इकोनॉमी को। एंड ही सेड, अरशद साहब, Pakistan's 99% population earn less than 100,000 rupees a month. 99%. If you earn more than 100,000, you are among the lucky 1%. 92% people earn less than 30,000 a month. Around 61.5% people earn less than 10,000 a month. Maybe in 2 years, these figures may be a little up or down. But can you imagine, with this kind of income curve, if tomorrow morning you need few 100,000 rupees for a serious catastrophic surgical intervention, आप बताइए कहां से आएंगे? यार, पिछले 2 सालों में, 3 सालों में जो हमारी हालत हुई है इकोनॉमी की, एक फैमिली बजट की, ना चादर का पता, ना सर का पता, ना पांव का पता। 2, 4, 5, 10, 12 लाख में तो आजकल कैबेज होता है एक प्राइवेट सेटअप में। कहां से आएंगे वो पैसे? यार, गरीबी अमीरी दुनिया के हर मुल्क में होती है, कैलिफोर्निया से लेकर भाई फेरू तक, एवरीवेयर। हर आदमी, हर खानदान अपनी आमदन के एतबार से अपने लाइफस्टाइल को एडजस्ट कर लेता है। बड़ा घर, दरमियाना घर, छोटा घर, बड़ी गाड़ी, दरमियानी गाड़ी, छोटी गाड़ी, बाइक, पैदल। बच्चे को 4 खिलौनों की बजाय 2 खिलौने, बेगम को 2 जोड़ों की बजाय 1 जोड़ा ईद पर, ये तो मुमकिन है। लेकिन यार, जब आपका कोई प्यारा आपके सामने जिंदगी और मौत की कश्मकश में स्ट्रेचर पे तड़प रहा हो, तो वो बेटा या बीवी या मियाँ या बाप वजीर आजम का हो या किसी जुम्मन कसाई का, तो आप बताइए उसे कैसे मरने के लिए छोड़ने का हिम्मत हो सकती है किसी भी खानदान के लिए। इसमें कोई नहीं छोड़ता यार। क्या करते हैं फिर वो खानदान? क्या करता है वो खानदान? उस जान को बचाने के लिए, उस बाप को बचाने के लिए, उस बेटे को, बीवी को, मां को, whatever the relationship could be, they put every damn thing on stake, every damn thing, just to save the life, उस खानदान को बचाने के लिए। फिर क्या होता है? घर बिकते हैं, गाड़ियां बिकती हैं, जानवर बिकते हैं, जेवर बिकते हैं, और कभी कभी तो वो सब कुछ भी बिक जाता है जो कभी नहीं बिकना चाहिए। बट स्टिल देयर इज अ 50% चांस कि आपका प्यारा जिंदा सलामत घर वापस लौट के आ सके। बट इन बोथ द केसेस that particular family fall below the poverty line for the next 4 generations. इस अजाब का, इस मुसीबत का, इस सैलाब बला का सामना था पाकिस्तानी कौम को जब 2015 के आखिरी दिन 31 दिसंबर 2015 के हुकूमत पाकिस्तान ने इस कैटास्ट्रोफिक हेल्थ केयर एक्सपेंडिचर के सैलाब के आगे बला बांधने के लिए सेहत कार्ड का इजरा किया। दिस वाज द बैकग्राउंड। I just wish to share the context. ये इतना सादा नहीं है। We can do 100 hours long academic discussions, but I'm giving you both policy and practitioner perspective. आज के दिन जिस लम्हे में आपसे मुखातिब हूं, 17 करोड़ 50 लाख पाकिस्तानी, whole of AJK, whole of GB, whole of ICT, whole of KP, whole of Punjab, which is the 10th largest nation in the world by population wise, district Tharparkar of Sindh, they are fully covered under the health insurance scheme, national health insurance scheme. यार आज भी अमेरिका के अंदर, यूनाइटेड स्टेट्स ऑफ अमेरिका में एल्डरली पॉपुलेशन को रात को नींद इसलिए नहीं आती कि कल सुबह अगर हेल्थ केयर एक्सपेंडिचर कैटास्ट्रोफिक हो गया कैसे काम चलेगा? With these kind of realities, 175 million of Pakistani sleep with a peace of mind कि कल सुबह कोई मुसीबत आई, कल सुबह कोई मुसीबत आई तो सिर्फ शनाख्ती कार्ड जेब से निकालना है। 1082 पैनल हॉस्पिटल अक्रॉस पाकिस्तान फ्रॉम कराची टू गवादर, they can go and they can take cashless free treatment from there. इस पीस ऑफ माइंड की यार क्या कीमत है? There is no price. It is priceless. पीछे मुड़ के देखिए अपने खानदानों में, अपने घरों में, अपने दोस्तों में, जिनके साथ बूढ़े माँ बाप होते हैं, कैसे जिंदगी, कैसे भाई एक दूसरे के हम माँ बाप को शिफ्ट करते हैं कि यार मेरे तो बजट ही नहीं है, खुदा ना खास्ता कोई मुसीबत आ गई तो अम्मा को लेके कहाँ जाऊंगा, अब्बा को कहाँ घसीटता फिरूंगा। जब हम ये हेल्थ कार्ड लॉन्च कर रहे थे, खासतौर पे पिछले साल जब हम यूनिवर्सल कर रहे थे, वर्ल्ड बैंक, IMF, WHO, any other international organization, everybody seeing us and watching us very skeptical. वो कह रहे थे कि यार पाकिस्तानी कौम with such a vulnerable economy, with such a weak health system, is it too ambitious? क्या आप ये लग्जरी अफोर्ड कर सकते हैं? पाकिस्तानी, क्या आपके बस की बात है? And we used to have every other day meeting in either the Prime Minister House or elsewhere कि यार इतना जो हम बड़ा ख्वाब को ताबीर देने जा रहे हैं 1 जनवरी 2022 से, कहीं ये बैकफायर तो नहीं कर जाएगा? Every other day, Prime Minister Sahab and rest of the Health Minister Sahab and the team member, they used to ask, अर्शद साहब कहीं ऐसा तो नहीं होगा शेखुपुरा हॉस्पिटल के बाहर लोग हेल्थ कार्ड पकड़ के खड़े होंगे and there will be service delivery network will choke down? फाइनेंस मिनिस्टर साहब पूछते थे, अर्शद साहब ऐसा तो नहीं होगा कि फाइनेंशियल यूटिलाइजेशन आसमान पे पहुंच जाएगी और जो स्टेट ओन्ड हेल्थ इंश्योरेंस कंपनी है, स्टेट लाइफ कॉर्पोरेशन, कहीं यार वो दिवालिया तो नहीं हो जाएगी? And we used to assure them scientifically, yeah, these are the number of beds, this is the average length of stay, this is the disease burden, with this kind of track record, कुछ नहीं होने वाला। हम कहते थे प्राइम मिनिस्टर साहब को और हेल्थ मिनिस्टर साहब को, फिक्र ना करें, ये तो होगा कि लोगों को इलाज के लिए शायद शेखुपुरा से लाहौर जाना पड़े टर्शरी केयर के लिए, ये तो होगा कि लोगों को गिलगित से शायद इस्लामाबाद आना पड़े, बट रेस्ट अश्योर्ड कोई बेड की कमी का सामना नहीं करना पड़ेगा। And there is no possibility with the all next 10 years financial projections, कोई कंपनी, इंश्योरेंस कंपनी हमारी या हुकूमत पाकिस्तान दिवालिया नहीं होने वाली। अल्हम्दुलिल्लाह, वी आर थैंकफुल टू द गॉड। दिस वन ऑफ द फास्टेस्ट एंड लार्जेस्ट एवर इन द हेल्थ इंश्योरेंस इंडस्ट्री। ये प्रोग्राम रोल डाउन हुआ, न कहीं भीड़ लगी, न कहीं चौक डाउन हुआ। पाकिस्तान का जो मीडिया है, वो जो सोशल मीडिया है, कितना हाइपर वाइब्रेंट है। मेरे मीडिया के दोस्त मुझसे जरा बेहतर जानते हैं। बड़ा प्रॉब्लम हो जाता, खुदा ना खास्ता ऐसी कोई चीज हो जाती, बड़ा बैकफायर हो जाता। फिर तो कोई हिम्मत ही ना करता आगे किसी यूनिवर्सल कवरेज की, हेल्थ इंश्योरेंस की कवरेज की हिम्मत। बट अल्हम्दुलिल्लाह, इट्स डन सक्सेसफुल। नाउ वी, इट्स नॉट क्रेडिट टू मी, इट्स नॉट क्रेडिट टू द हेल्थ मिनिस्टर, इट्स नॉट क्रेडिट टू द प्राइम मिनिस्टर, इट्स नॉट क्रेडिट ओनली फॉर द गवर्नमेंट ऑफ पाकिस्तान, इट्स फॉर एवरीबडी, ऑल ऑफ यू। ये हमारे कौम के लिए बाइस फख्र है कि वी कैन डू मीनिंगफुल एंड यूजफुल थिंग्स फॉर अवर नेशन। याद है, एक रूलर नारा लगाया करता था पाकिस्तान में, सबसे पहले पाकिस्तान। I have a little variety, little change to this slogan. I always say, सबसे पहले पाकिस्तान। पाकिस्तानी होंगे तो पाकिस्तान हो। पाकिस्तान दीवारों का नाम नहीं है, पाकिस्तान मेरा और आपका नाम है। We are Pakistani. As rightly mentioned, कि पहली बार नेशनल सिक्योरिटी में ह्यूमन सिक्योरिटी को डाला गया। अदरवाइज कौन सी सिक्योरिटी है यार? आप और मैं बिस्तर पे पड़े हों, which security we are talking about? Fancy jargons, बड़े खूबसूरत हम अल्फाज इस्तेमाल करते हैं whenever we go anywhere in the international forums or elsewhere. There is no security. So we cover hospitalization coverages, more than 1,082 hospitals across Pakistan. Cashless treatment, your CNIC is your health card. 70% private hospitals, 30% public hospitals. 1.5 months ago, I was sitting with my counterpart in Ankara, with Turkish National Health Insurance head. And he was asking me, Arshad, how you can manage a private sector? हमारे पास तो आज भी वो कहते हैं कि जब कोई Turkish health card holder with only 82 million population, keep in your mind, when they go to a public sector hospital, they need to pay copay 0. But when they go to a private provider for the service, they need to spend an OOP from 100% to 200%. कहते हैं अर्शद यार तुम्हारे यहाँ क्या होता है? I said, if Pakistani health card goes to a government hospital, he needs to pay 0. And when he goes to a private sector hospital, he needs to pay 00. He said, how come? This is how we are managing the system. It's not rocket science. We are not perfect. We are perfectly imperfect, as I always said. हमने भी फी फॉर सर्विस से काम शुरू किया था, हमने भी अपने सबक सीखे, हमने भी धक्के खाए, हमें भी हॉस्पिटल्स ने, कुछ फनकार हॉस्पिटल्स ने सीखने का, फास्ट ट्रैक पे सीखने का मौका दिया. But today, whenever we take this program to any international forum, like a nation like Germany, which is the 140 years oldest health insurance nation in the world, they pay respect to our program. They pay respect to our nation. Last week, I was in Thailand for an international family planning conference. I was having a multiple leadership meetings with the counterparts. And when one of the UK-based Mary Stopes president, global president, Mr. Simon Cook, and when we shared the story, when we shared the data with him, he said, Arshad, like any other foreigner expert, it's too good to believe. I said, please come over, have a look. Have a look. Every day, 25 to 30,000 admissions are taking place. एक जान को बचाना इंसानियत को बचाना होता है. Every day. Go to the hospital. See yourself. All the people sitting here, आपके ही कुछ अजीज, कुछ दोस्त, कुछ स्टाफ, कुछ colleagues, उनके रिश्तेदार जरूर गए होंगे. You can see yourself. Most of the hospitals are good. Most of the doctors are good. Most of the policy makers are good. There are few who have a problem with us. My colleague is sitting here with me. She sees and she can witness every other day, Ambassador Raza, I have a delegation of Orthopedic Association, Cardiac and Thoracic Surgeon Association, and they ask me, Arshad साहब, आपने तो बड़ा मुश्किल कर दिया हमारे लिए. हमने कहा जी क्या मुश्किल कर दिया आपके लिए? कहने लगे जी आपने कीमतें बड़ी कम कर दी हैं. हम तो कोई 10-12 लाख रुपए कैबिज का चार्ज करते थे, हम तो सिर्फ 3.5 लाख रुपए देते हैं. मैं कहा जी वी हैव अ कॉस्ट प्लस ट्रांसपेरेंट पैकेज सिस्टम, अगर आपकी कॉस्टिंग में कोई चेंज आई है तो वी कैन ऑलवेज एडजस्ट इट। एंड बाय द वे जस्ट इन लास्ट 8 months all this devaluation and inflation we adjusted thrice the cardiac prices। कहने लगे नहीं जी पहले बड़ा मजा आता था, अब आपके आने के उस प्रोग्राम के आने के उस सिस्टम के आने के बाद तो बड़ी मुश्किल हो गई है। मैंने कहा खुदा का खौफ करें, आप 2 रुपए की कॉस्ट पे 18 रुपए प्रॉफिट चार्ज करते थे, दुनिया में कहाँ होता है यार। वी डू ए कॉस्ट प्लस costing for you, we put all the costing inputs, we adjust 10 to 12% margin for the complicated cases, we add 25 to 30% profit margin for the hospital, still that is not good enough for you। दुनिया में बाकी जगह कहाँ होता है बताइए, खुदा का खौफ कीजिए, फारिश में देखिए, look here, health and education are not for profit sector, जो पैसा कमाते भी तो R&D में लगाते हैं यार, कहाँ होता है ये। या दुनिया में और पूरे 2000 शोबे पड़े हुए, मेक प्रॉफिट, मेक मनी, इंप्रूव योर लाइफस्टाइल, गो कैलिफोर्निया, गो लॉस वेगस, जहां जाना है जाओ यार, सेहत को तो छोड़ दो यार, तालीम को तो छोड़ दो, मेहरबानी करें। एक जहनी सेहत के लिए, एक जिस्मानी सेहत के लिए कोई पता तो नहीं है कब मैंने, आपने, वजीर आजम ने, इन्होंने, एक्स ने, वाई ने कब उस स्ट्रेचर पे जाके लेटना यार। क्यों भूल गए हो कराची के उस सर्जन का वाकया यार, जो पैसे लिए बगैर ऑपरेशन नहीं करता था, जिसका अपना बेटा एक दिन जख्मी होकर आया था, जब पूछा कि पैसे जमा करा दिए हैं, कहने लगे अभी तो कोई पीछे आया नहीं है, लेकिन उसकी जान खतरे में है। पैरामेडिक्स बड़ी पुश किया डॉक्टर साहब को, डॉक्टर साहब कहने लगे नहीं यार आपको मेरा उसूल सिस्टम पता है, पैसे जमा नहीं होंगे तो ये तो नहीं हो सकता। Every 10 minutes paramedics were asking him, every 10 minutes he was refusing। फिर क्या हुआ, फिर क्या होता है जब 2-2.5 घंटे बाद उसकी बीवी अपने बाल नोचते हुए उस अस्पताल की इमरजेंसी में दाखिल हुई और दोनों ने मिलकर अपने जवान बेटी की डेड बॉडी उठाकर रोते हुए बाहर निकले उसी अस्पताल से। There are commercial or not commercial, ruthless approach people, but there are so 99% of people, वो डॉक्टर इतने अच्छे हैं कि वो साथ किराया भी देते हैं मरीज को कि यार घर भी चले जाओ। These are the realities। लोग पुरानी 20 साल पहले की स्टोरी नहीं सुना रहा आपको, मैं आपको 2 महीने पहले का लाहौर का वाकया बता देता हूँ। मंजूर जूनियर, अवर ओलंपियन, मंजूर जूनियर गोल्ड मेडलिस्ट, वी प्राउड ऑन हिम, कि जिसने हमें गोल्ड मेडल जीत के दिया था, पाकिस्तान की कौम के माथे का झूमर है। तो 1.5 महीने पहले की स्टोरी है रजा साहब, जब उसको सुबह 3 बजे लेके भागे घर वाले कि जिसको MI हुआ है, पता नहीं 2 या 3 स्टेंट डाले उस प्राइवेट हॉस्पिटल ने, पता नहीं जिंदगी की हालत में डाले थे कि मुर्दा होने की हालत में डाले थे, और फिर 4 लाख के बिल के पीछे उसकी डेड बॉडी को लॉक कर दिया था हॉस्पिटल में। उनका जी पैसे जमा कराएं तो फिर अपने बंदे को उठा के ले जाए। उसकी बीवी, उसके बच्चे रोए चिल्लाए, बताया कि कौन है, उन्होंने कहा जी हम तो मजबूर हैं, हम तो जी एम्प्लॉइज हैं। फिर वो बेवा, फिर वो बच्चे, वो सारी उस डेड बॉडी को वहां छोड़ के दे रैन टू द लाहौर पाकिस्तान हॉकी फेडरेशन हेडक्वार्टर। तो कहा खुदा के वास्ते PHF, या तुम्हारा बंदा था, तुम्हारा प्लेयर था, जाके गारंटी दो अस्पताल में, डेड बॉडी उठा के घर लेके जाएं यार। Then PHF given a written guarantee and the family was able to take the family this dead body at home। These are the realities। 20,000 के पीछे बहुत से अस्पताल, बहुत से लोग नहीं डेड बॉडी रिलीज करते यार। So with this kind of situation, health card become a blessing for common Pakistani, for even for the affluent Pakistani। यार हेल्थ के मामले में तो सारे गरीब हैं। हमारे एक बहुत अच्छे फेडरल सेक्रेटरी हुआ करते थे, अल्लाह खुश रखे उनको, डॉक्टर अल्लाह बख्श साहब, वो कहते थे मुस्कुरा के, कहने अरशद साहब जो बंदा सीधा चल रहा है ना, तो और सीधे अपने कमाई के अंदर चल रहा है, तो वो तो सेक्रेटरी भी हो तो ज़कात दा मुस्तहिक होता है। अगर एक 22 ग्रेड का अफसर अपनी आमदनी के अंदर, मीन्स के अंदर और हलाल जरिए से रहे, तो आप सोचिए बाकी जो 99% की जो मैंने बात की वो कहाँ जाएंगे यार। This is the only human side, this is only the social side। Let me give you a couple of technical side issues as well। किया क्या सेहत कार्ड ने? आज सारे हेल्थ सिस्टम के माहिरीन, दुनिया के चैंपियन हमसे पूछते हैं जी ये तो ठीक है जी आपने फाइनेंशियल प्रोटेक्शन दे दी, लोगों की जानें बचा ली, ये किया क्या आपने? It revolutionized the public health in Pakistan, but we need to do more। पहले अगर डेरा बुगटी के अंदर कोई बीमारी की वबा फैला करती थी तो सिर्फ कोयटा खबर आने तक हफ्ते गुजर जाते थे और इस्लामाबाद तक तो मुद्दतें गुजर जाती थी। बट टुडे आई कैन शेयर विद यू द रियल टाइम डेटा के गुजरांवाला में लास्ट वीक में किस बीमारी ने पीक किया था, टंडोला यार में किसने किया था और गिलगित के बर्फजारों में किसने पीक किया था। वी हैव द रियल टाइम डेटा। जहां कोई मुसीबत आए वी कैन ऑलवेज अलर्ट आवर पब्लिक हेल्थ टीम टू प्रीएम्प्ट, कम डाउन, उस बीमारी को वहीं महदूद करें कबल इसके को फैला के पूरे पाकिस्तान की ऐसी की तैसी कर दे। दिस इज द पब्लिक हेल्थ इंप्लीकेशन। एक और बात बताऊं, सर्विस डिलीवरी 75 years, nuclear nation, 43rd highest economy GDP in the world. Pura Balochistan, 46.4% of Pakistan, except the DHQ or whatever civil hospital Quetta. वो छोटा सा एक वो खुददार में थोड़ा सा काम करता है। पूरा बलोचिस्तान खाली, no reliable secondary care or tertiary care facility available. एक कराची, आधा हैदराबाद, चौथाई सक्खर, whole of the upper Sindh is khali. Punjab, except Lahore and Nishtar, now Muzaffargarh after Tayyib Erdogan Hospital. South Punjab is khali. KPK, एक Peshawar, आधा Abbottabad, khali, no service delivery, reliable service delivery. And pardon me when I talk about AJK and GB, बड़ी शर्म आती है ये बात करते हुए आपके सामने. Both being a citizen and both being a representative of the government of Pakistan. यार 75 साल हो गए पूरे एजेके में, पूरे जीबी के अंदर हम लोग बहैसियत कौम जिन्होंने और बर्फजारों की जंग के अंदर यहाँ सारा इंफ्रास्ट्रक्चर पहुंचा दिया, पूरे एजेके जीबी के अंदर एक कार्डियोलॉजी फैसिलिटी और एक ऑन्कोलॉजी फैसिलिटी 75 साल में नहीं बना सके। कैन बी प्राउड ऑफ इट। वो दो हिस्से, वो लाखों मिलियंस लोग जिन्होंने अपनी विल पे जंग लड़के पाकिस्तान में शमूलियत इख्तियार की थी, उनके लिए हमने खुंजराब में, फस्सू में, नीलम में किसी को अगर एमआई होता है, दिल का दौरा पड़ता है तो यार इस्लामाबाद पहुंचने तक 3 दफा वफात पा जाएगा वो। क्या कसूर है उसका? तो हाउ सेहत कार्ड इज ट्रांसफॉर्मिंग दिस सर्विस डिलीवरी। फाटा पसमानदा तरीन इलाका पाकिस्तान का 2 साल पहले यूनिवर्सल किया हमने। 25 to 30% न्यू हॉस्पिटल्स इमर्ज इन द प्राइवेट सेक्टर। आप सब नौजवान है ना, आप एंटरप्रेन्योरशिप का अपनी बड़ी कहानियां सुनी होंगी बिजनेस स्कूल्स के अंदर। व्हाट यू नीड टू बी एंटरप्रेन्योर, एक दुकान खोलने के लिए, कारोबार खोलने के लिए, चाहे वो बहरिया टाउन कॉम्प्लेक्स की तरह का अजीम एम्पायर हो या एक छोटा सा पान का ढाबा हो। व्हाट 2 things you need, one is a target customer जहां आपने दुकान खोलनी है, the other one is the purchasing power in the pocket of the target customer. Every Pakistani is a target customer for the health, and everybody, at least 175 million have in their pocket, in the shape of their health card, a purchasing power today. तो हर जगह प्राइवेट सेक्टर एक्टिव हो रहा है, नए हॉस्पिटल खोल रहा है। केपी सिर्फ 1 साल पहले यूनिवर्सल किया हमने, एक्सेप्ट पेशावर एंड एट टाइम्स एट एबटाबाद, इसके अलावा कहीं कार्डिक इंटरवेंशन नहीं होती थी। नाउ वी हैव मोर देन 13 कैथ लैब्स इन द फार रिमोट एरियाज ऑफ द डीआई खान। वहां भी एंजियोप्लास्टी हो रही है यार। क्या सेहत कार्ड के बगैर ये मुमकिन था कि रियासत पाकिस्तान उल्टी भी हो जाती अपने 75 सालों के अंदर? क्या वो सर्विस डिलीवरी नेटवर्क बना सकती थी? नेवर, नॉट पॉसिबल। सप्लाई साइड से हम डिमांड साइड पर आए हैं, प्राइवेट सेक्टर को इंगेज किया है। 70% आज प्राइवेट सेक्टर अस्पताल मेरे पास हैं। I assure you, subject to the continuity of this wonderful program, next 5 years, Pakistan service delivery network will be totally changed. And last but not the least, now we have rolled down universal health insurance, but we need to reach to our UHC goal. Zafar Mirza Saab knows, he was with us last year. We had a primary healthcare OPD pilot project in Islamabad, which we just done the close of service last month, sir. And now we are doing a couple of more primary healthcare projects, one in Muzaffarabad, one in Lahore. I always call about PP. It's not public-private partnership. PP means preventive and primary care. Now we are doing a pilot project. Shahzad is not here with the help of the Health Service Academy. So we need to integrate this secondary care and tertiary care model with the primary health care and then with the preventive health care. That is the only way forward. यही तरीका इंटीग्रेटेड हेल्थ सिस्टम को इंट्रोड्यूस करने का. There is no other way. सारे पब्लिक हेल्थ के माहिरीन, हेल्थ सिस्टम के माहिरीन, हमारे जो बहुत अच्छे दोस्त होंगे, यही कहते हैं अच्छे साहब बहुत जरूरी है. Yes, it's very essential, very important. $1 we spent in prevention, we save $10 in the primary, and $1 we spend in the primary, we save $100 in the secondary care and tertiary care. It's not only about bucks. सिर्फ पैसे नहीं बचाने हमने जाने भी बचानी है. जिस चीज को हम प्रिवेंशन से बचा सकते हैं, उसको सेकेंडरी केयर, टर्शियरी केयर में आके मरने का गैम्बल क्यों खेलें यार? We have to do it, and we will do it. With last sentence, being a nation, being a citizen of Pakistan, if we can change one walk of life, थोड़ा सा ही सही, imperfect ही सही, we can be proud of, we can get the confidence. अगर हम पाकिस्तानी कौम जिंदगी का एक शोबा ठीक कर सकते हैं, तो इंशाल्लाह बाकी शोबे भी हमसे दूर नहीं. बहुत शुक्रिया.
Thank you so much, sir, for working for the welfare of the community and also providing us the very thoughtful information regarding the Sehat Sahulat program and also improving the healthcare system of Pakistan. Now, I would like to welcome Dr. Qais Saeed, the Chief Executive Officer of Islamabad Health Regulatory Authority, to put up his views and ideas regarding the healthcare regulation in Pakistan.
Thank you very much. Assalamu alaikum. The speakers before me touched upon very important areas of health service delivery. And we also discussed about the components of health service delivery, promotive healthcare, treatment, prevention, rehabilitative services. We also talked about universal health coverage and the Sehat Sahulat card. But I think the most important thing to deliver services is the quality of services. Without quality of services ensured, you may have a catastrophic outcome of the services that you are providing. So, aap hospital ja rahe, hospital gaye, and instead of coming out cured, sometimes you come out with more diseases. Rather, in some cases, you come out as a dead man or dead person. This is just because that the healthcare service delivery, the quality has to be ensured. Now, what do you think? How safe healthcare service delivery is worldwide and even in Pakistan? So you see, we have very dangerous sports activities, bungee diving. We have mountaineering, considered to be quite dangerous. But then on the other hand, commercial airlines, the aviation industry, and the European railroads are much, much safer compared to getting admitted in our hospitals. And similarly, driving in US and chemical manufacturing facilities are much safer. Nuclear power plants are much safer than actually getting admitted in the hospitals. So for aircraft accidents, there is 1 in 125 million passenger journeys. For a rail travel accidents, there is 1 in 43 million passenger journeys. For rock climbing, there is 1 in 320,000 climbs. For scuba diving, which is considered quite dangerous, there is 1 in 200,000 dives. For hand gliding, 1 in 116,000. But for maternal death, it is 1 in 8,200. That's the situation we are facing. So actually, if we consider health as an industry, the most dangerous industry is actually health industry. Now, what are the factors why aviation industry is much safer compared to healthcare? And we all know that. And you must be watching on your television programs on accident investigation, air accident investigation on National Geographic. And you must have seen how methodically they investigate accidents and near misses. So what they do, they use checklists. They have checklists for routine operations. They have checklists for complex operations, and they have checklists for emergency operations. In health, in America, they tried to introduce these checklists. And they introduced the checklist when the patient got surgery and they came out from surgery into the ICU, they used the checklist. Similarly, when the nurses were changing, they used checklists to hand over the patients and their directions and use of medicines to the next coming batch of nurses. Just because in these two areas, when they introduced these checklists, they drastically reduced medical errors and the consequences of those medical errors. So we have this training of staff. Although in medical practice, doctors get training, but the rigorous training that aviation industry give to their pilots has no comparison with what we give to our doctors. Investigation of incidents and near misses, you have all seen this, how methodically they investigate. What about our incidents? Who investigates in our hospitals if there is a death or if there is an infection, nosocomial infection into the hospital? Who does that? Who reports that? And who takes that action so that it is not repeated again? I don't think so. As healthcare regulators, we get regular complaints from patients. All the big hospitals of Islamabad, we are getting complaints. We have penalized hospitals, public sector and private sector hospitals, because of this malpractice and medical errors. Reporting of incidents without culture of disciplinary action. We have this culture of disciplinary action attached if we report incidents or near misses, not in the aviation industry. So what are the things? So if you see how reliable an industry is, there are certain criteria for that. So if you see on the y-axis, 10 minus 1 means 1 time out of 10, the performance is substandard, or 9 times out of 10, the performance is of standard, required standard. Healthcare is somewhere between 10 minus 2 and 10 minus 3. But what about aviation industry, which is somewhere around 10 minus 6 and 10 minus 7? The reason, simple. Process design. The processes are designed in the aviation industry to minimize variations, not in health. Reliability culture. Strong human performance reliability that minimizes human error. Human factor integration. Virtually impossible to do the wrong things. आपने जहाज में देखा होगा, when it is coming low, there is an indicator saying your height is low, or constantly there's a beep or there's an alarm. We don't have such systems in healthcare that alarms you and does not allow you to perform errors. These are the things that we have to learn probably from our aviation industry. This cheese model, Swiss cheese model, is quite popular. There was a psychologist called James Reason who actually presented this cheese, Swiss cheese model. And it says that there are several layers in a cheese with holes. So in a health system, and similarly in aviation industry, if you make a mistake at level 1, it may stop in the second layer. If you make mistake in the second layer, it may stop at the third. So you have several systems in a health system, even in aviation industry, to stop mistakes that we make. Some of the examples, and I'll quote one example that was reported to Islamabad Healthcare Regulatory Authority. A young patient of 35 years age got admitted in the hospital for polyp, removal of polyp with the nose. Very simple operation. The surgeon operated on the polyp, but in the notes forgot to write medications for pain. Because after the operation, when the patient recover, they feel pain. So there was no painkiller. The patient got out. So that was the first mistake, first layer mistake. The second, the patient was brought to the ward, and there was a medical officer who was supposed to write the notes and then even the medication for pain, but he didn't do it. Second mistake. When the patient got out of anesthesia, she said she has a lot of pain. So the husband of the patient went to the attending nurse and asked that, she feels a lot of pain. So we need some kind of analgesic, painkiller. And the nurse went to the doctor who was doing a round and asked her to write a painkiller. And he said, I'll come over, but I am busy. And ultimately, the doctor didn't come back. He went out. And then the nurse had to write herself. So she wrote on a small paper, medicine which is used for general anesthesia, injection Acuron. The third mistake. And instead of writing on the patient file, she wrote on a small paper, which is quite common in our hospitals. And the husband took the prescription to the pharmacy of that hospital. And this is a private hospital. Fifth mistake. The pharmacist sitting in that pharmacy immediately gave that medicine to the husband of that patient. Sixth mistake. The injection was brought in and the nurse injected the drug to the patient. Seventh mistake. And the patient instantly died. And this case was reported to us and we are taking an action. Now, these are the layers which should have stopped this error, medical error, to happen. But, the systems were not there, the SOPs were not there, the training was not there, the checklists were not there. And ultimately, a patient died age 35 with children for a small operation of polyp removal in Islamabad a few months back. That's the situation which is happening. And that's the role of regulators which comes in. It says that, for an average serious outcome, there are 8.3 human errors. In one of the hospitals in America, they calculated a small child got killed, and they calculated that there were 16 opportunities to stop this happening. But this happened. So many medical errors, so many problems in the hospitals that needs to be fixed. Now, what are the roles? This is what our roles are as regulators. Ask yourself, when you go to a hospital, aapke dil mein to aata hoga, is this doctor competent enough with the latest knowledge? Am I getting the best possible medical care when I am in the hospital? You all have this fear. Who sets the standards of care in healthcare settings? That's where a regulator's role come in. It is to protect the healthcare of consumers from health risks, provide safe working environment for healthcare professionals, ensure that facilities comply with public health policies and standards. Definition. Regulation is sustained and focused control exercised by a public agency like Islamabad Healthcare Regulatory Authority, and the promises we had healthcare commissions over activities which are valued by the community. The key feature of regulation is that it involves third-party regulators like ourselves to oversee the performance. Now, why we have put in so many regulators and regulations, not only in Pakistan, but worldwide? And this is increasing. I'll give you example of NHS England, where regulations are increasing with time. Regulators to achieve equity, efficiency, and affordability. And the quality is the most important thing that needs to be regulated, and the regulators are actually regulating them. Hold powerful corporate, professional, or social interest to account. We have strong private sector now, and Dr. Arshad was actually talking about most of their patients now going to the private sector. 60% of our population is already, to our statistics, are going to the private sector to seek medical health. Most of our patients are actually not willing to go to the public sector hospitals. Only those go to the public sector hospital who cannot afford private sector. That's the reality. And why don't they want to go to the public sector hospital? Although it's a big hospital and they have all the facilities available and all the trained doctors are there, but nobody wants to go there. Especially the serious patients are being referred to the private sector hospitals from far-flung areas. KP, most of our serious patients are referred in a private sector hospital in Islamabad. AJK, Gilgit-Baltistan, patients are coming to Islamabad. More so to the private sector hospital. What is the reason? Why people are more inclined to private sector compared to the public sector? The only reason is quality. The quality of care is much, much better than the public sector hospitals. And we have lots of problems of public sector hospitals to say regarding the poor quality of services that they are offering. This is just National Health Services England, where in 2002, they conducted a study and they said 126 organizations exert some regulatory influence on NHS provider organizations, in addition to 211 clinical commissioning groups. So much regulations are being implemented in England. And in Pakistan, a few days back, somebody told me, how many authorities do you have? Healthcare Regulatory Authority, Healthcare Commission, Human Organ Transport Authority, Blood Transfusion Authority, Drug Regulation Authority. Why so many authorities? Just because we need to regulate. And simple example is, we see it daily. When we are on the motorway, we behave. When we come out of the motorway on the GT road, we don't behave. Simple reason. There's a regulator sitting over there who is watching you and penalizing you. That's why we behave on the motorway. Immediately when we come out on the GT road, we know that regulator is not there. And then Nobody cares in which lane, how to overtake and what to do. So many organizations. This is how a healthcare regulator works, not only in Islamabad, but in all the provinces. We have these standards. We develop standards of care, and then we train healthcare providers on how to achieve those standards. And we give them sufficient time to improve their standards and services and checklists and indicators. And then we go for their assessments. We do their assessments. And then when we find them to be of good quality, we give them licenses, or we don't give them licenses. And if we don't give them licenses, they are not allowed to practice. That's how we regulate. And then we regularly do these inspections, not only on these hospitals, but the quackery in Pakistan, which is so rampant everywhere, even in Islamabad. What to talk of rest of the country? We are full of quacks in the outskirts. We go outskirts, quacks are every day, flourishing businesses that they have. And we have examples. I have a video where in a quack clinic, they are using veterinary medicine. It's written over there, only used for veterinary, red, and they're still using in Islamabad. A month back, I have this video. That's the situation happening in Pakistan. I give you an example. Few months back, there was a murder, Noor Muqaddam, we all know, and we all have heard about that. So the drug addiction centers in Islamabad, we have about 45 drug addiction centers. When we went there, this is the situation in those drug addiction centers where they put them on treatment for 10 days in prison-like conditions, in bunk beds, 20 patients in one room. And one of the patients with the skin disease on the head, he said that I haven't seen the sunshine for the last 6 months. This is how we treat our drug addicts in Islamabad. What to talk about far-flung areas of Balochistan, Sindh and Punjab. What will be happening over there, you can well imagine. So what we did, we developed standards of care with UNODC, UN Agency for Drug and Crime. This was equivalent. These standards were as good as anywhere in the world. So these standards are now developed. And then we trained all these people who are working in drug addiction centers. And this is an international training curriculum on which we train them. And now we are going to go assess them and we'll give them licenses. Future of quality healthcare in Pakistan. Not a good picture, quite a dismal picture, but we rank 154th out of 195 countries in terms of quality of care that we are providing. And this is a Lancet study. But the ray of hopes are there in Pakistan. Universal health coverage schemes will improve our quality. And then the health insurance schemes will certainly give push towards the quality culture in Pakistan. Now, this is 4 dimensions of quality of healthcare. This was described by a great author called Daniel Cohen. And he said that for quality, you should have at least four dimensions. Number one, accreditation and certification of hospitals and community-based services. This is one of our mandates. So we do accreditation through Pakistan Accreditation Council. Clinical quality performance measurement and improvement. We develop standards of care and then we do assessments based on those standards. Patient safety assurance and harm prevention. Minimum standards of care have been developed national level and in the provinces as well. And patient experiences and perception of care. There's a strong complaint management system in these healthcare commission and regulatory authorities where they actually penalize the hospitals and the healthcare professionals. This was National Health Service England. They say regulatory systems should develop standards. We are doing that. provide incentives to high performing providers. In Islamabad, we are introducing this star rating of healthcare facilities. This is the first time in Pakistan we are going to star rate them so that the high performers should be distinguished from the low performers, because ultimately we are going to put a cap on their costs as well. So costing will also be done based on the star rating. Allow flexibility for the providers depending upon the context in which they are operating. So HCCs allow sufficient space to providers to improve their performance and standards. Involve stakeholders in the development and assessments of the standards, and we are actually doing this. We have developed all our standards in consultation with our stakeholders, including the hospitals and the healthcare providers who are working in Islamabad, and same is the case with the Healthcare Commission in their provinces. My last slide is actually on patient safety and how it improves lives and reduces the cost. 21% reduction in hospital-acquired conditions since 2010. This is 2010 and 2015. 3 million fewer adverse events, 125,000 lives saved, and about $28 billion in saving in that 5 years when we introduce quality standards in healthcare in US. Thank you very much.
Thank you so much, Dr. Said. Now I would like to request our last honorable speaker, who does not require an introduction due to his renowned personality, Sir Lieutenant General Asif Mumtaz Sokhera, Hilal Imtiaz, military retired, Vice Chancellor of Mohammedan Islamic University and ex-Surgeon General of Pakistan Army. I would like to request him to please present his presentation on healthcare supply chain. Thank you.
Bismillah ar-Rahman ar-Rahim. Honorable Chair, dignitaries, ladies and gentlemen, and fellow students, Assalamu alaikum. It's very difficult to speak at the end of any, forum, or because वो कहते हैं कि सुन के सुन हो चुके होते हैं लोग. Anyway, I'll try to be brief in my topic, which has been given to me, supply chain management, which is, I'm a doctor, so I know it's a dry topic. Having served in the army for almost 35 years, I know it is the one job that any doctor would avoid is working in a medical store, as in charge of the medical store, because it's a thankless job, and fulfilling all the requirements, satisfying all the patients, to deliver them the drug of their choice, their demand, and prescribed by the worthy specialist. Just to refresh, supply chain management is basically flow of goods, raw material to the packaging or synthesizing factory or other, and then delivering the finished goods to the ultimate user. That is the science of supply chain management. And if we talk about the healthcare, that is the flow of medicines, medical products, healthcare services from manufacturer to patients, and helps ensure that healthcare providers and patients get the medication and treatment at the right time and at the right place. I have briefly, summarized into five components if we talk about the supply chain management. Of course, इसमें सारा एक complete dynamics है, how the things work, how a healthcare system works, which also includes the human resource, which is a very vital component, but I am restricting myself to the material, not to the men. And that includes the medicines, the disposable and surgical items, electromedical equipment, diagnostics, and implants and prostheses. Coming to the medicines, first of all, as we all know that most of the medicine They are common medicine that are in use. But what are the challenges? You all know, recently, the most common used medicine in Pakistan, that is paracetamol, is not available. And it was just yesterday I talked to the director of medical supplies in the army, and he told me that the civil health authorities have been approaching the army to please share of some of the stocks that you have with you. So that is the state of affairs. If we talk about the emergency medicines, then again, there are a lot of things that are required, and at times they are short in supply. एक छोटी सी मिसाल मैं आपको दूंगा. We started with a pharmacy business. I was tasked by on retirement to establish a pharmaceutical or business venture of healthcare in Army Welfare Trust, and we started a company with the name of MedAsk. And we established about 30 pharmacies in a span of 3 years, established our own lab and about 30 or 35 collection points all over the Pakistan. I consulted various specialists during my tenure in military hospital and combined military hospital. And I asked that, what is your demand and what are the things which are not available in the pharmacy that you would like to have with you? So, very useful things came in. Like a child specialist, he told me that if a child with epilepsy, if the child has a fit at home, what is the remedy? How can you save the child from a fit which can be fatal? Of course, you can't give it orally because the child is in a state of fit, and the child may even, aspirate his own vomit. So the only option is to give an injectable. Of course, the parents can't do it if they are not from the healthcare profession. They have to then rush the patient to an emergency. So he said that in UK, a nasal spray is available which can halt the fit. So that is a simple thing which is not available in Pakistan. So these are some of the things, the challenges that we need to work on. That what are the requirements in Pakistan? If we talk about the anti-cancer drugs, फौज में भी एक सर्कुलर आ जाता है कि जी एंटी कैंसर ड्रग्स शॉर्टेज में है, लेकिन आपने इंडिया की यूज नहीं करनी. सो दीज आर द चैलेंजेस. मैं इस चीज को हायर लेवल पे हाईलाइट कर रहा हूं दैट आवर हेल्थ केयर सिस्टम नीड्स टू आइडेंटिफाई what are the problems, what are the bottlenecks, and we need to work at a higher level to ensure that the appropriate drugs are available to each and every citizen. If we talk about the palliative and terminal care, मुझे कई लोगों ने अप्रोच किया कि जी हमारा पेशेंट है, टर्मिनली इल है, कीमोथेरेपी हो चुकी है, सर्जरी हो चुकी है, अब बस आखिरी स्टेजेस पे है, बट ही इज इन अ लॉट ऑफ पेन. सो व्हाट इज द ट्रीटमेंट? वो कहते हैं जी मॉर्फिन टेबलेट है, लेकिन वो मिलती नहीं है, काउंटर पे नहीं मिलती, वो फलां हॉस्पिटल से मिल सकती है. सो देन यू टू टॉक टू दोज हॉस्पिटल्स के यार ये पेशेंट है, वो कहते हैं जी प्रिस्क्रिप्शन दें, हमारे हॉस्पिटल में होगा तो वील गिव यू द मेडिसिन, अदरवाइज इफ इट इज समवेयर एल्स वी कांट गिव द मेडिसिन because the DRAP has very strict control. आपको कॉलेजेस के बाहर हेरोइन और चर्च और सब कुछ मिल जाएगा, लेकिन एक टर्मिनली इल पेशेंट जिसकी जेन्युइन रिक्वायरमेंट है उसके लिए आपको मेडिसिन अरेंज करना, दैट इज अ प्रॉब्लम. And the medicine companies, pharmaceutical industry is a huge industry. And I have been involved as a surgeon general, as deputy surgeon general in some of the planning at higher levels, even invited in the presidency about 3 times on various matters of national interest. और उसमें ये कुछ ड्रग्स की शॉर्टेज और उनकी कॉस्ट का था कि जी मैन्युफैक्चरर्स दे आर नॉट प्रोड्यूसिंग अकॉर्डिंग टू आवर रिक्वायरमेंट बिकॉज दे वांट द कॉस्ट ऑफ मैन्युफैक्चर इज सो लेस दैट यू हैव फिक्स्ड दैट वी कांट प्रोड्यूस दैट. आप सबके नॉलेज में है thyroxine is very important and life preventive medicine for a patient with hypothyroidism because of accident or anything. Lekin thyroxine at times, is not available in the market. So you are rushing here and there, asking various military hospitals, some bigger hospitals for the supplies. So then the pharmaceutical industry, they have their own excuses that we are short of raw material, which is not available. We have limited supplies, import के problems हैं, dollar and rupee parity वो हर साल down जा रहा है, उसके problems हैं, cost of production. And then there is monopoly of certain organizations. कि हमने उनको एक license दिया हुआ है, only they can import, nobody else can import. I'm just summarizing few of the highlights, not going into the details. If we talk about the disposable and surgical items, एक Foley's catheter जो है, उसकी cost जो है 50 rupees से लेके 250 rupees तक है. And somehow the surgical items, they don't carry a price tag. आप कहीं पे भी syringe लेने जाएंगे, उसके ऊपर cost नहीं लिखी होगी. So there are, you know, hundreds of thousands of items, list of items of surgical items, जिसमें कोई क्वालिटी कंट्रोल नहीं है, कोई प्राइस का कंट्रोल नहीं है, और जो दुकानदार जिस तरह चाहता है उसको वो चार्ज करता है. एंड दैट इज वन ऑफ द मनी अर्निंग, जो लोग जो कॉन्ट्रैक्टर्स हैं, वंस दे टेक द कॉन्ट्रैक्ट फ्रॉम ए हॉस्पिटल और बिगर हॉस्पिटल, तो वो कहते हैं कि जी इतनी हमारी इसमें कमाई है. आई हैव ऑब्जर्व्ड एज ए सर्जन कि एक पेशेंट को लिस्ट लिख के दी जाती है कि ये डिस्पोजेबल आपने लेके आने अपने पेशेंट के लिए सुबह. वो जब एक थैला लेके आता है 5-7 हज़ार का, उसमें वो गैस भी होगी, सब बाकी चीजें भी होंगी. अल्टीमेटली एट द एंड ऑफ द डे, आई हैव बीन चेकिंग ऑल दिस थिंग्स. कई लोगों के उसमें 1/3 यूटिलाइज हुआ होगा, किसी का हाफ, किसी का 75%. वो बाकी किधर जाता है? क्योंकि मैंने ये पूछा कई दफा, कोई पेशेंट था बहुत पुअर था, मैंने कहा यार देखो, आई एम नॉट आस्किंग यू टू वेव ऑफ योर फीस, मैं चलो दे दूंगा या कहीं से अरेंज करूंगा. वो कहते हैं जी चले हम मेडिसिन भी अरेंज कर लेंगे, वो हमारे पास पेशेंट की बची हुई पड़ी होती है. सो देयर इज नो अकाउंटेबिलिटी फॉर दैट. And who pays for that? The poor person out of his pocket. Intervention cost, जो intervention procedures, you know, with the development of medicine, अभी जो gastroenterology है, वो ultimately it's all intervention. If we talk about radiology, it is again all intervention radiology. Pulmonology, सारी चीजें हैं. अब इसमें कुछ disposables use होते हैं. So I contact the head of gastroenterology in military hospital and I ask him that, what do you want from me? He says that if I have to do an ERCP, the cost of disposables at present from the contractor that we are getting is about 75,000. And if we take away, because they offer us commission for every item, कि जी आप ये चीज यूज करेंगे, आपको इसमें से kickback हम आपको इतना देंगे. So if you pay us according to the market cost, तो पता लगा कि वो 75,000 cost came down to 15,000 rupees. So this is what is going on. If we talk about the other thing, I'll come to that. Stents. Even the Chief Justice had to intervene to fix the cost of the stent because everybody was charging at its whims. So I went to, you know, the people, कि जी क्या है actual cost कितनी है? पता लगा कि 20-25 हज़ार है, जिसके 90 हज़ार या 1 लाख हम चार्ज कर रहे हैं. और कुछ स्टैंड्स जो हैं वो 2.5 लाख 3 लाख के भी मिल रहे हैं. और ये भी पता लगा कि जी डॉक्टर्स के लिए ये पैकेज है कि जी apply one, get one free. So वो कॉस्ट उनकी पॉकेट में जाती है. आई डोंट वांट टू डिस्कस, वो पहले बात किसी ने की थी कि नेगेटिव बातें नहीं करनी, आपने सॉल्यूशंस की तरफ जाना है. Electromedical equipment, huge sum, you know, in billions we spend every year, even in the army. और इस पे भी मोनोपोली है certain companies के जी आप उन्हीं के थ्रू इंपोर्ट कर सकते हैं. वेंटिलेटर, यू नो, जब मैं सर्जन था तो it used to cost 18,000 to 25,000 rupees. आज उसकी कॉस्ट जो है वो 5 to 7 million है. And during COVID, you know, a very useful campaign went on कि जी why can't we produce our own ventilators? और मैंने अभी पूछा लोगों से, उन्होंने कहा जी that failed because बने हैं लेकिन मार्केट में आने नहीं दिए. डॉक्टर्स ने कहा we don't prefer that, we prefer that coming from abroad. उस पर कितना हमारा फॉरेन एक्सचेंज लगता है every year in import of this equipment. And ले लेते हैं, लेकिन उसके बाद क्या है कि that doesn't work. Because we don't have in the country a good biomedical engineering setup to maintain the equipment. And that is one thing, you know, which is failing our healthcare system. उसकी वजह से हम क्या करते हैं कि हम जो गवर्नमेंट हॉस्पिटल हैं, मैंने जो I mentioned you that I was called a number of times in the presidency. At one time, one of the agenda was how to make PIMS functional. आप अंदाजा करें कि फेडरल गवर्नमेंट का इट इज द ओनली बिगेस्ट हॉस्पिटल, लेकिन वो कंप्लेंट ये थी कि प्रेसिडेंट ने कॉल किया, पास्ट प्रेसिडेंट रिटायर्ड, कि जी कैसे इसको हमने फंक्शनल बनाना है. सो दिस इज द स्टेट ऑफ अफेयर्स के जिसमें गवर्नमेंट के बिलियंस ऑफ रुपीज लगते हैं. आई हैव बीन ऑन द बोर्ड ऑफ फातिमा जिन्ना मेडिकल यूनिवर्सिटी, बीइंग मेंबर ऑफ HEC. I had attended number of meetings, and hats off to Dr. Yasmin Rashid, who used to chair all the meetings, and even during her illness, she used to travel that morning from Lahore and reach at the conference right in time, rather 5-10 minutes before the time. और वो ये जो अभी हेल्थ सेहत सहूलत कार्ड की बात हो रही है, डॉक्टर साहब ने कहा बड़ा आई एम रियली हैप्पी दैट दिस इज गोइंग ऑन, और मैंने इसको कई दफ़ा कॉन्टेक्स्ट भी किया कि हाउ कैन वी run this system or सेहत सहूलत कार्ड parallel to a government system where we are already investing billions of rupees. So, but it is delivering results. And he said that because of that, the healthcare sector has come up, and that would be also a wake-up call for the public sector hospitals. I am sorry, वो नहीं होगा सर, क्योंकि वो हमारा हाल पीआई वाला है कि जो पीआई में काम करने वाले हैं, जहाँ से रोजी खाते हैं, उसी को खा रहे होते हैं कि ये खत्म हो जाए. तो ये अल्लाह करे कि ये चीजें ठीक हो जाए. Electromedical equipment, this is the problem that we have been facing in the army also. उसके लिए फिर you revert to the engineers, they have their own system कि जी हम once we purchase the equipment that then you have a contract for annual maintenance contract, or that also goes in millions कि कैसे आपने उसको maintain करना है, but it is worth it. एक छोटी सी आपको मैं दूँ, I shared an experience with a colleague. He was working in FC Hospital, Frontier Corps Balochistan Hospital, back in late 90s. And they thought of procuring a CT scan because the civil government in Quetta, this district headquarter hospital, was also procuring the CT scan. So they approached the vendor and they gave a quotation. The civil hospital purchased, but the FC hospital didn't purchase because they thought it's a very expensive machine. And we don't have so much of workload that we need to go, and so we'll use the facility from the civil side. So the vendor came and he said, sir, you asked for a quotation, but you are not, getting a machine for yourself. He said that we don't have the money. He said, you invest the money, we'll make sure that your machine will work and the one in the civil hospital will not work. उसने कहा, how is that possible? उसने कहा, सर एक छोटा सा पुर्जा आगे पीछे करना है, वो हमारा काम है, हम कर देंगे. So there's a lot of huge impact on foreign exchange. Local manufacturers को हम facilitate ही नहीं करते. There are a lot of manufacturers from world over who come here, they want to invest. Chinese ने हमें कई दफा कहा है, हमें बाहर की Turkish government ने कहा है, because they have a very robust system. Even Chinese came कि जी हमारे पास जो फैक्ट्री है जो सीटी स्कैन बनाती है, वो 2 लाइंस हैं. एक वो है जो ओरिजिनल मैन्युफैक्चरर है, वो हमसे लेता है, और दूसरी लाइन में वही प्रोडक्ट हम आपके लिए बना के देंगे. सो दिस इज व्हाट आई वांट टू से, दैट द स्टेट नीड टू इंटरवीन and put its foot down to have these facilities available for the public at appreciable price. Diagnostic equipment. Especially I'm talking about the labs. इसमें भी एक माफिया है. There are few vendors जो lab kits को import करते हैं और उसी से वो पैसा कमाते हैं. और they are they have hijacked the specialists, especially in the private setups. और वहाँ पे एक I went into this कि जी एक जो टेस्ट होता है उसकी कितनी कॉस्ट आती है, तो पता लगा कि if we charge 100 rupees, at times the cost is 10 rupees or maximum 40 rupees. तो बाकी 60 रुपए या 80 रुपए वो क्या जी, वो टोटल मुनाफा है. और उसमें से द डॉक्टर्स आर पेड कि जी अगर आप जितने टेस्ट एडवाइस करेंगे, शाम को 25% शेयर आपको घर में डिलीवर हो जाएगा. सो दिस इज गोइंग ऑन. This is happening in America also, because I have talked to some of the doctors working there. They say that when a patient comes, we say, is he insured? They say yes. Okay, then instead of 7 tests, you advise 12 tests. क्योंकि कंपनी ने पे करना है, लेकिन हमारा भी होगा, इसमें शेयर होगा. Reagent rental is another option. In the army, we went for it. That instead of purchasing the equipment of lab equipment very costly for all the hospitals, why not to go for reagent rental? What is this? That one company says that we are going to put in the machines in your hospital. We'll ensure 24/7 serviceability. And the only thing is that you have to pay the cost of kits that we'll be purchasing. So that is it. Finally, implants and prostheses, orthopedic surgeon, eye specialist putting on the intraocular lens. गोडे डलने हैं, वो कहते हैं कि जी फौज में आपने क्यों नहीं कर रहे, क्या कर रहे हैं. हमने कहा कि यार ये 2.5 लाख का जो एक गोटा डलना है, इसमें पता नहीं आप कितने लोगों को माइनर ट्रीटमेंट्स के लिए अवेलेबल कर सकते हैं। इसी तरह लैसिक ऑपरेशन, द लेजर सर्जरी, जिससे कि आप यू रिमूव द स्पेक्टिकल्स। तो आर आई स्पेशलिस्ट दे वर कंटेस्टिंग कि जी इसकी जो किट है 70,000 की, वो आर्मी इसको बेयर करे। मैं कहा व्हाई शुड आई, you have to put off the glasses, that's it, that you want to do. कहते नहीं जी, इसराइली जो आर्मी है उसने अपने पायलट्स के लिए करवाया ताकि they can get rid of the glasses. मैंने कहा पहली बात तो ये है कि in the army once you induct, you make sure that the person comes in with a 6x6 eyesight. अगर आपने इसको एक रिटायर होने वाले सूबेदार के लिए करना है तो मैं 75,000 उसके लिए पे करूं, वो IOL कराए, अपना कैटरेक्ट करवाए और उससे वो रिटायर हो जाए. So lot of things that we need to done. What is the way forward? Third line पे आप आ जाए. मैं ये कह रहा हूँ कि जिस तरह एक गवर्नमेंट, सिटिंग गवर्नमेंट हिल जाती है कि जी शुगर की शॉर्टेज हो गई है, शुगर की बड़ा कॉस्ट बढ़ गई है, आटा अवेलेबल नहीं है, आटे की प्राइस चली गई है इतनी, गवर्नमेंट हिल जाती है, दे मेक ए कमीशन, दे इन्फोर्स एवरीथिंग, they enforce that they know, they are in knowledge of all the stocks available in the country, the manufacturers, and what they need to do to control, to deliver to the common man. Same steps we need to take for the delivery of supply chain management in healthcare. Thank you very much.
Thank you so much, sir. Let's now move to the last part of today's seminar, on which I will request all the guest speakers to come up on the stage before the panel discussion starts.
जी बिस्मिल्लाह। डॉक्टर जफर आप प्लीज ऊपर आ जाइए, पैनल डिस्कशन है तो आई वुड लाइक यू टू बी अप। जन साहब आप भी ऊपर आ जाइए प्लीज। अच्छा जी, थैंक यू वेरी मच। इट हैज बीन अ लॉन्ग टायरिंग सेशन, इस चीज़ को हम अंडरस्टैंड करते हैं। थोड़ा सा और पेशेंस और खाना रेडी है गर्मा गर्म, तो आफ्टर दिस देन एक पैनल डिस्कशन है। पैनल डिस्कशन के बाद वोट ऑफ थैंक्स है, वोट ऑफ थैंक्स के बाद एक ग्रुप फोटो एंड देन वी विल हैव लंच इंशाल्लाह। ठीक है जी। डॉक्टर जफर मिर्जा साहब हैज टू लीव अर्ली, तो आई वुड रिक्वेस्ट कि इफ एनीवन हैज एनी क्वेश्चन और कमेंट, क्योंकि हमने जो स्पीकर्स थे सुबह से उन्होंने काफ़ी कुछ कवर कर लिए। तो द आइडिया ऑफ दिस डायलॉग इज़ कि हम जैसे कि एक प्रेजेंटेशन में डॉक्टर जफर मिर्ज़ा ने मेंशन भी किया, उनका जो 8 पॉइंट एजेंडा था उसमें ये था कि वी हैव टू गो फ्रॉम पॉलिसी साइड टू द इम्प्लीमेंटेशन साइड। तो ये इपरी के साथ हमारा हाथ में लाना और इस डायलॉग के प्रोसेस को शुरू करना, इट इज़ अ वे to devise policies and then inshallah go and move slowly towards the implementation. Dr. Clark, do you have anything? The Chinese delegation is there. If you have any queries, would you like to? जी please, mic है तो mic दे दें इनको। जी इसके पास।
Good afternoon. Myself, Dr. Huma Shafi, hailing from Gilgit-Baltistan. And I enrolled in MSPH in HSA. And as Dr. Qaid Saeed mentioned, there is no proper checklist, or there are no subsidies, or there is no accountability to any mishap or any mortality, which is counted as unexpected. Unexpected in sense के like एक कॉमन डिजीज है जो इजिली क्योर हो सकती है एक हॉस्पिटल में, और ऑल ऑफ अ सडन डेट मैन जो है ना वो लाइक उसकी डेथ हो जाती है। ठीक है, तो वहाँ पे कोई अकाउंटेबिलिटी नहीं है। इज माई सेल्फ सफर्ड फ्रॉम दिस टू, दैट्स व्हाई आई एम लाइक एक्सपीरियंस मैं अपना शेयर करना चाहूँगी आप लोगों को। वो ये है कि लाइक 2 to 3 months back I had a C-section and I delivered a baby boy, And the baby was cried, like he well cried, and he was like with fully and good APGAR score, and there was no obvious deformity or no any other like he was not having any problem. Like the hospital shifted him to the nursery in the name of prematurity, and after 2 to 3 days, I had a call from nursery that Dr. Saiba, aap aa jaye, like we have to hear something. So when somehow I managed to go there, and at their like they brought that bad news. We have been like मतलब ये मेरे साथ मेरे बेबी like नहीं अभी है मतलब I can't explain that situation कि उन्होंने मुझे ये बताया कि आपका बेबी जो इतना जो है ना बिल क्राई था, इतना सब कुछ था सही से, जो मैंने विटनेस किया था कि he was doing well, vitally stable, no obvious deformity. मैंने खुद उनको मुझे लाके दिखाया गया, फिर उनको शिफ्ट किया गया हॉस्पिटल, लाइक नर्सरी शिफ्ट किया गया. जब मैं गई हूँ वहां पे तो उन्होंने मुझे ये कहा है. तो डिस्चार्ज के टाइम लाइक आई समहाउ मैंने कहा कि मुझे बेबी की फाइल दिखाएं. अब मैंने फाइल देखी है तो देयर वर मल्टीपल कॉजेस. उन्होंने मेंशन किया हुआ था कॉज ऑफ डेथ में, बाज जगह मेंशन था कि कंजेनिटल एनोमली है, बाज जगह मेंशन था कि आपका जो बेबी है उसको पल्मोनरी हैमरेज हुआ था, बाज जगह मेंशन था कि जो है ना कार्डियक अरेस्ट हुआ है. लाइक आई वाज नॉट श्योर कि कॉज क्या थी, मेंशन ही नहीं था प्रॉपर. तो देयर शुड बी accountability, there should be SOPs to inquire about these sudden mortalities. So this is what I have.
Thank you.
Thank you so much.
जी, ये जनाब कायद सिंह साहब.
अच्छा, फर्स्ट ऑफ ऑल आपके दिल की जो आवाज है वो मैंने फील की है, जैसे वो भरा गई आपकी आवाज, उसको मैंने फील किया है. और एक माँ की दुख की जो आवाज होती है वो हम सबको पता है, हम सबकी माएँ हमने फील की हुई अपनी माओ से. तो पहले तो मैं आपका दुख समझता हूँ कि कितना सख्त था. सबसे बड़ा डिलेमा शायद पाकिस्तान का है ही यही इस वक्त भी कि एक्स डॉक्टर बहुत अच्छा सर्जन है, सारी दुनिया उसके पास जा रही है, उस तरह के FRCS 5 और है, उसके पास कोई नहीं जा रहा. उसकी सर्जरी बेहतर है लेकिन बाकियों की सर्जरी के बारे में शक है. क्या हमने अपने हॉस्पिटल्स के अंदर अपेंडिसेक्टमी की चेकलिस्ट कभी देखी है कि अपेंडिसेक्टमी करने के लिए क्या क्या प्रोसीजर्स होते हैं, कट कहाँ लगता है, कितनी लेयर्स खुलती हैं, किधर स्टिच लगते हैं? क्या कभी कोई किसी ने चेकलिस्ट देखी? मैंने तो कम से कम नहीं देखी, ना मैंने आज तक कभी ऑब्जर्व किया. खासकर पब्लिक सेक्टर हॉस्पिटल में जहाँ मैं ट्रेन हुआ कोई चेकलिस्ट नहीं है. क्या हमने सिमुलेशंस किए हैं जैसे एविएशन इंडस्ट्री में वो लोग इमरजेंसी अगर हो जाए या आपसे कोई कॉम्प्लिकेशन हो जाए कैसे हैंडल करना है? हमने ट्रेनिंग दी नहीं, हमने कोई ट्रेनिंग नहीं दी. हम डिपेंड करते हैं स्किल्स ऑफ अ सर्जन. इफ अ स्किल्ड सर्जन इज देयर वी ऑल डिपेंड ऑन हिम. इफ इज नॉट देयर और कोई नया सर्जन आ गया वी डोंट ट्रस्ट हिम बिकॉज वी डोंट हैव अ मैकेनिज्म उसको ट्रेन करने का, उसको मॉनिटर करने का. जो आप बात कर रही है वो एक और अलग इशू है कि हम रिपोर्ट ही नहीं करते. हम जो मैंने अपनी प्रेजेंटेशन में कहा कि एडवर्स इवेंट्स जब गुजरते हैं उसके बाद कोई इन्वेस्टिगेशन होती है, उसको किसी ने देखा जाता है और उसके बाद अपने सिस्टम्स को स्ट्रेंथन करने के लिए कोई एक्शंस लिए जाते हैं. नेवर. एंड दैट्स व्हाई वी डोंट चेंज. दैट्स द डिफरेंस बिटवीन अस एंड द गुड इंडस्ट्रीज दैट आई मेंशन इन माय प्रेजेंटेशन. तो आई टोटली एग्री. मेरा अपना ख्याल है कि यहाँ रेगुलेटर का बहुत बड़ा फंक्शन आता है कि वो इसको इन्वेस्टिगेट करे और कॉज ऑफ डेथ मालूम करने के बाद जिससे गलती हुई है चाहे उसको पेनलाइज करते हैं, दिस इज समथिंग एल्स. दैट सिस्टम शुड बी पुट इन प्लेस कि आइंदा किसी और माँ के साथ ऐसा सलूक ना हो. वी हैव टू स्टेप इन, वी हैव टू डू इट. Very true. Yeah.
चलिए
एक
ठीक है
छोटा
जी,
सा-
थैंक यू।
छोटा सा एग्जांपल
जी जी प्लीज।
यूनिसेफ ने अभी चंद दिनों पहले एक वर्कशॉप MNCH पे कराई थी हेल्थ सर्विसेज एकेडमी में, जहां उन्होंने आपके गिलगित बल्तिस्तान का एग्जांपल दिया कि हमने जिन लोगों को ट्रेन किया था वो लोग वापस आए और उन्होंने ऑब्जर्व किया कि सिंपली बाय मेंटेनिंग द टेम्परेचर ऑफ द OT जहां पर डिलीवरीज हो रही हैं, उन्होंने मोर्टेलिटी को ड्रास्टिकली रिड्यूस किया बच्चों में, सिर्फ टेम्परेचर कंट्रोल। और वो भी गिलगित बल्तिस्तान में जहां इतनी सख्त ठंड पड़ती है, वहां उन्होंने टेम्परेचर को मेंटेन करने के बाद बहुत सी मोर्टेलिटी रोकी है। सिंपल चीज। अच्छा, ओके ओके ओके।
I just would like to add, Bashir, at the health card, we have not given option to a patient to choose a doctor, but we given an option to choose a hospital, any hospital, because we treat every doctor who has a degree or PMDC membership, is equal. And we're also introducing STP, what is mentioning standard treatment protocols. And we do take the notice wherever possible, and we do impanel the hospitals, but we need a lot of support from our regulator partners. I must say, I think things will improve. Don't worry, but I can understand your pain.
ठीक है, थैंक यू। राबिया बलोच, आपका क्वेश्चन था, बोलिए प्लीज।
them that they can make CT scan of civil hospital, and why were they not easy to talk about this with civil? So this should be investigated. Like, you people cannot always like throw bombs on civilians. There are some things in army also, as he was comfortable talking to you and not to civil people. So this should be investigated. And my second question, it's not a question, it's rather a suggestion for Dr. Said. Like you were telling about healthcare regulations, and as you said that there is a lot of work to be done in civil hospitals. And as this doctor mentioned, my great sorrows and sorry for her, she lost her baby. If only IPC protocols can be applied in civil hospitals, then doctors are very competent. We have to work on IPC as well. And then when I joined, as I joined late, but we were talking about universal health coverage. So you were talking about it. So I know it's being implemented in Balochistan soon, and the pilot study is going on in Turbat and Las Vegas districts, and registration as well. But I don't know, and I'm not sure, do you people know that there is no hospital in Sobatpur district? Yes, it is a district of Balochistan and it's suffering from floods. So if there is no healthcare services over there, no hospital for admissions, then how you people are going to implement universal health coverage in those areas of Balochistan? So these are my questions.
अच्छा, थैंक यू वेरी मच। एक तो क्वेश्चन थोड़ा सा स्पेसिफिक रखें और प्लीज इतनी ज्यादा डिटेल्स में ना जाएं, ठीक है? एंड नो पर्सनल क्वेश्चंस टारगेटिंग एनी ऑर्गेनाइजेशन और इंस्टीट्यूशन, प्लीज। अभी बात हुई है कि वो जो इंसिडेंट हुआ है उनका जो मोर्टेलिटी हुई है, दैट वाज इन रावलपिंडी। वी ऑल नो, वी हैव बीन डिस्कसिंग फॉर द लास्ट 3 hours. देयर आर चैलेंजेस नॉट ओनली in 1, 2 or 3 places, but everywhere in Pakistan we have issues. तो आई थिंक इस पे अरशद साहब कुछ कहना चाहेंगे, और आई थिंक आप इस पे जरा सेहत सहूलत कार्ड के हवाले से भी बता दें कि उसकी कवरेज सिंध, बलोचिस्तान और GB और फार फ्लंग एरियाज में।
सिंध बलोचिस्तान में हमने पायलट प्रोजेक्ट किया था इन द फेज 1। आपको पता है कि हेल्थ जो है वो 18वीं तरमीम के नीचे डिवॉल्व है सूबों के पास। तो सिंध एंड बलोचिस्तान येट टू ज्वाइन द मेन यूनिवर्सल हेल्थ इंश्योरेंस प्रोग्राम। Last year, it's almost worked out everything for the Balochistan. Team भी develop हो गई थी, budget भी allocate हो गया था, but there was some change in the political regime there. तो अभी थोड़ा सा वो shelve है, but we are talking to the Balochistan and Sindh as well to join the program. तो उसके बाद पूरा 23 करोड़ 40 लाख पाकिस्तान इसमें definitely cover हो जाएंगे। आपकी बात बिल्कुल ठीक है बेटा। मसला ये है कि पहले मरहले पे तो आज भी बलूचिस्तान के पेशेंट या DG खान जाते हैं या कराची आते हैं। तो पहले मरहले पे तो हमको ये सहूलत दें कि कम से कम उनको अपनी चीज़ें बेचने ना पड़ें या कोई पैसे गुर्बत का शिकार ना हो कम से कम। तो दूसरे मरहले पे जैसे मैंने गुजारिश की कि डिलीवरी नेटवर्क आहिस्ता आहिस्ता बड़ा होगा। जब बलूचिस्तान गवर्नमेंट यूनिवर्सल हेल्थ इंश्योरेंस इंप्लीमेंट कर देगी तो पीपल लाइक यू एंड सो मेनी अदर कॉलीग्स हियर, दे विल गो टू देयर होम टाउन्स, वो जाके अस्पताल खोलेंगे। उनको पता है कस्टमर भी मौजूद हैं, परचेजिंग पावर भी मौजूद है, then we'll see a real change, but it's not too far.
जी भट्टी साहब.
Thank you very much, sir. My name is Mohammed Waqar Bhatti and I am a journalist. मेरा क्वेश्चन अर्शद साहब आपसे है. एज अ लेमैन मैं ये जानना चाह रहा हूँ कि पाकिस्तान की पॉपुलेशन ग्रोथ जो है 1.9% है इस वक्त, और हम पॉपुलेशन को, जो पॉपुलेशन एक्सप्लोजन हो रहा है पाकिस्तान में, इसको जो क्लाइमेट चेंज है उससे भी बड़ा एक खतरा समझा जा रहा है. यूनिवर्सल हेल्थ इंश्योरेंस में यू फैसिलिटेट द पॉपुलेशन ग्रोथ. आई मीन मतलब ये भी एक डेटरेंस होता था पहले, जब तक यूनिवर्सल हेल्थ इंश्योरेंस नहीं थी, कि यू हैव टू कीप द फैमिली साइज स्मॉलर. बट एक हमें लग रहा है, मतलब इट इज नॉट, मैं कोई मजाक नहीं कर रहा हूँ, लेकिन मुझे और लोगों ने भी कहा ये फीलिंग है कि इट कैन लीड टू आई मीन पॉपुलेशन ग्रोथ और एक्सपोनेंशियल ग्रोथ इन पॉपुलेशन. आप इसको कैसे देखते हैं? थैंक यू वेरी मच.
जी, आपका तबसरा गलत नहीं है. जैसे मैंने बताया कि लास्ट वीक आई वाज इन द वर्ल्ड्स लार्जेस्ट इंटरनेशनल फैमिली प्लानिंग कॉन्फ्रेंस. वहाँ भी कई माहिरीन ने ये सवाल हमसे किया कि जी आप मैटरनिटी कवरेज जो है वो हेल्थ कार्ड में देते हैं. सच्ची बात ये कि हम देते हैं. द रीजन बीइंग जो ऑलरेडी बेबीज इन द जर्नी है या पाइपलाइन में है, उनकी बच्चा और बच्चे के दायरे जान तो हमने बचानी है. बहुत कम, स्पेशली इन द रूरल सेटअप, आई मस्ट से, आप सब मेरे दोस्त वहीं बैकग्राउंड से, मैं खुद एक पेंडू आदमी पिंड से हूँ, तो आपको पता है कि वहाँ कोई जो हमारे लोग हैं वो बहुत प्लान नहीं करते कि जी वो पैसे होंगे कि नहीं होंगे. जो होना होता है वो हो जाता है. वो पायलो कोयलो जो बोलता है ना, जब जब जो होना है तब तब सो होता है. वो आहिस्ता जो 99% जो तीसरा चाइल्ड होता है वो तो वैसे भी एक्सीडेंटल होता है, आपको पता है. तो दिस इज हाउ इट गोज. बट वी आर थिंकिंग ऑन अ सीरियस नोट, हैविंग सेड दिस, कि despite all our religious sensitivity with the issue, हम प्लान कर रहे हैं कि नेक्स्ट फेज में हम ये करने जा रहे हैं भट्टी साहब एंड फॉर द रेस्ट ऑफ द कोलीग्स, कि जो पहली मैटरनिटी होगी उसको हम 100% सब्सिडाइज करेंगे, दूसरी 50%, और तीसरी मेरे ख्याल माँ बाप को कुछ खुशी खुद भी कॉस्ट बेयर करनी चाहिए. तो वी आर प्लानिंग दिस, बट यस इशू इज ऑन द टेबल. मैं हमेशा कहता हूँ, क्योंकि आई एम फॉर मोर देन अ क्वार्टर सेंचुरी इन द हेल्थ इंश्योरेंस बिजनेस. इवन जो प्राइवेट सेक्टर में हम इंटरनेशनल मार्केट में जब ये हेल्थ इंश्योरेंस सेल करते थे, आई यूज्ड टू से मुबशिर साहब कि इट्स नॉट अ डिजीज, मैटरनिटी इज नॉट अ डिजीज, इट्स अ सेल्फ इन्फ्लिक्टेड इंजरी और सेल्फ इन्फ्लिक्टेड खुशी, व्हाटएवर यू कॉल इट. सो थोड़ी सी खुशी जो है माँ बाप को बर्दाश्त करना चाहिए. वी हैव टेकन योर नो. थैंक यू.
Assalamu alaikum. Professor Dr. Mati Rahman, humble learner of quality and safety. I have the honor to conduct audits locally and internationally. The Dr. Sahaba case is a typical example of two things which quality teaches us. Things which are not seen are not done. So that is monitoring. And before that, things which are not documented are not done. I have seen that I also have been an honor to work for the Lajna Tibbiya, they call in Saudi Arabia, who investigate the quality deaths and other things. I have seen the doctors who apparently look very knowledgeable, but when we saw their file, they were missing a lot and they were punished. They had to pay 100,000 riyal like that. The other guy who looks to be not a good doctor, but his documentation was excellent. So the documentation part, and very important is, as we were just discussing, I think only few years back, it was easy to open a hospital because we did not need a license. This is a positive thing happened in Pakistan, that in front of our eyes, now we have regulatory body who are regulating. And I won't say that it's perfect. Nothing is perfect. And till our standard is not accredited by SCUA, because unless it is accredited by SCUA, it has no value. I was very ashamed when I was sitting in a meeting in Singapore, and the other guy sitting with me was from India, and he said, our policy, our standard has been accredited, and we are accrediting other countries' hospitals. So I think this is something not new. If as a regulator, you must be knowing that such cases are too much, and most of them are not reported. This is the tip of the iceberg we are talking about. Thank you very much.
Thanks very much. जी एक ये क्वेश्चन, इसके बाद लास्ट क्वेश्चन, then we have to wind up. Thank you. जी प्लीज.
मेरा नाम डॉक्टर ताहिर शरीफ है. मैं एक बड़ा अहम इशू है, इस पे मैं बात करना चाह रहा हूँ कि हमारे जो टीचिंग हॉस्पिटल्स हैं, आप उसमें देखा होगा कि जो मेरा एक्सपीरियंस है कि जो भी पेशेंट्स आता है उसको पहले हमारे जो हाउस ऑफिसर्स होते हैं वो उसको देखते हैं। जो मेडिकल कॉलेज का अभी न्यूली एक पास आउट हुआ हुआ डॉक्टर होता है, हाउस जॉब कर रहा होता है, वो 3-3 महीने की शिफ्ट पे आता है मुख्तलिफ डिपार्टमेंट्स में, और वो सबसे पहले इमरजेंसी को देख रहा होता है। तो लाइफ सेविंग के लिए तो इमरजेंसी मोस्ट इम्पॉर्टेंट है, और हमारे साथ सारे टीचिंग हॉस्पिटल में, हमारे सब हॉस्पिटल्स में यही क्राइटेरिया है। तो कोई ऐसा सिस्टम होना चाहिए कि जैसे अभी चेकलिस्ट की बात हो रही थी कि कोई एक्सपीरियंस लोग हों जो पहले सबसे उसको देखें, और बाद में वो मैनेज करने के लिए बेशक हाउस ऑफिसर साथ हो, लेकिन इनिशियली सारी असेसमेंट जो है वो उसका कोई एक्सपीरियंस होना चाहिए डॉक्टर का, वो एक फिक्स किया जाए।
सर ब्रीफ आंसर, क्योंकि खाना तैयार है, कम क्वेश्चन और कम छोटा छोटा।
नहीं अच्छा है, क्वेश्चन होने पे भूख ज्यादा लगी।
क्वेश्चन होने लगे।
जी जी बेटा बताओ।
Ji, Assalamu alaikum. I'm Dr. Faiza Aslam and I'm an academic researcher from Rawalpindi Medical University, and I have been working for 7 years as International Program Manager for NIHR funded research programs on mental and physical comorbidity. और मेरा ये point है कि we are talking about from policy to implementation, or research is the foundation of we need of every policy, we need evidence. और अल्हम्दुलिल्लाह जिस तरह पहले होता था कि our policies were based on the international research की findings के ऊपर था, even though there is inclination और हमारे पास research बहुत हो रही है, international funders are very much interested in conducting research in South Asia. But the problem is that there is, we are still working in silos. So whenever जो भी research आ रही है, it should be targeted to the priority areas of Pakistan and South Asia. Or the areas are defined by the international funders, which may not be relevant to our, countries. So जब भी कोई research program start होता है, तो मेरी एक humble suggestion ये है कि there should be a liaison between the policymakers and the researchers. They should be taken on board. There should be stakeholder events, consortiums होने चाहिए researchers के policymakers के अंदर, in which the policymakers should, emphasize on the priority areas in which they want our researchers to work. For instance, there are so many PhDs and master's program going on in so many institutions, or topic नहीं मिल रहा होता, supervisors और जो होते हैं सारे they are struggling to find relevant topics. So I have been part of the universal health package discourse, and unfortunately all the interventions they have been tested.
Thank you. Thanks very much. आपका क्योंकि मैं डायरेक्टर औरिक हूँ, औरिक को लीड कर रहा हूँ, तो मेरे काफी स्टूडेंट्स यहाँ पे बैठे हैं, तो आप लोगों से ये रिक्वेस्ट है कि when you think of a topic, think of an intervention in the community जिसका ग्राउंड लेवल पे फायदा हो। ये आप लोगों के लिए ये क्वेश्चन मैं आप लोगों पे वापस फेंक रहा हूँ, ठीक है? Do not come up with an idea जिसका कोई फायदा नहीं है community. Come with an idea that we can have an intervention at the community level, and based on that we can generate evidence and then scale up. Ji, thank you. You have to, Ji.
No, I was just going to make a quick comment. Thank you very much for the great talk. I think it's very good. I read a book a while back. It's called Super Crunching. And the question was asked, the pilots, they always follow a checklist, and why the doctors are resisting it. And the answer was very simple. The pilot is in the plane. Doctors not.
Ji, Brigadier Saab, the last question from the Brigadier Rashid Saab, if we say, then we will close.
Last question, जी खाना तैयार है।
रोटी खोलने वाली है।
Right. My question is, Arshad Saab, आपसे, or maybe, sir, you can also chip in. हम बात करते हैं universal health coverage and then say सहूलत. तो जफर मिर्जा साहब ने कहा कि there is some distinction. तो उस पे थोड़ा सा elaborate कर दीजिए कि वो क्या है. फिर ये जो whatever you are doing by way of say सहूलत, it's very impressive. But क्या ये sustainable है? पाकिस्तान 2% से और GDP से नीचे lowest spender in sub-Saharan Africa, South Asia. तो without spending, how can this be sustainable countrywide? और इसको आप कैसे वो sustain करेंगे?
जी मैं बता देता हूँ। आपके दूसरे सवाल का मैं पहले जवाब दे देता हूँ। Wherever I go to the Pakistan cabinet or to international forums, they always ask, क्या आपकी कौम और आपका खजाना या याशी अफोर्ड कर सकता है, वो जो आपने जरा सोफिस्टिकेट अंदाज में पूछा है. Yes, I always say yes at every forum, and we don't talk in air because it's too a tangible business. As we are talking about this fiscal year 2022-23, 4 provincial governments, 2 regional governments, and 1 federal government. 7 governments are spending 2020-22-23 budget is 1,000 billion rupees. 1,000 अरब पाकिस्तान के अंदर जो मेन स्ट्रीम, अभी मैं कॉर्पोरेशन की बात नहीं कर रहा हूं, अभी मैं आर्मी और मिलिट्री फोर्सेस की बात नहीं कर रहा हूं. 1,000 अरब 4 सूबाई हुकूमतें, 2 इलाकाई हुकूमतें और एक फेडरल गवर्नमेंट यूज कर रही है. 1,000 अरब. If I give health card to everybody, including Sindh and Balochistan, all 234 million Pakistanis, still my health card will be restricted to 230 billion. 230 अरब में हम सारे पाकिस्तान को हेल्थ कार्ड दे सकते हैं. Still you have $750 billion in your kitty to spend on primary health care, preventive health care, जो जफर मिर्जा कह रहे थे, palliative health care, promotive health care, जहां मर्जी लगाएं. पैसे की कमी नहीं है. With my little experience in Pakistan government or the international government, I am a former advisor for the UAE government as well. वहां भी universal health insurance इत्तफाक से मेरे हाथ से हुई थी. So it's not money, it's not resources. अच्छे लोगों की कमी नहीं, honestly speaking. It's all about 2 things. It's all about 2 things. One is privatization and second is ownership. That's it.
I'll take last comments from General Sukhera and then we will have group photo and then land. Ji.
I think he has.
So the public जो हमारे हॉस्पिटल्स हैं आरजीएच के बाद या पेम्स के बाद पिंडी में बना ही कोई नहीं. So जब वो नहीं बन रहे तो क्या ये
मैं उसी तरफ आ रहा हूँ. उन्होंने आपको आंसर कर दिया कि इट इज सस्टेनेबल, बट माय पॉइंट इज विद माय एक्सपीरियंस, और मैं कई फोरम्स पे बार बार बात करता हूँ कि ये जो कुछ मर्जी हम कर लें, दिस इज नॉट द आंसर. Whatever we do, this is not the answer. The answer is prevention. जब तक हम उस तरफ नहीं जाएंगे, whatever resources we create, they fall short of the increasing population. So we are not heading anywhere till we go for prevention.
चलें, बहुत शुक्रिया जी. We are very much thankful to all the stakeholders and specifically IPRI. और let's have a group photo and then off to lunch. Thank you.
फर्स्ट फ्लोर और आगे एहसान साहब, प्रोफेसर एहसान साहब इधर, बाकी लोग नीचे आ जाए. क्यों सर, डॉक्टर साहब